One. Sir, please start. We are live.
Okay.
Hello, good evening, Namaskar. It's a great pleasure to welcome you all for this exciting session on recent updates in lung cancer. This webinar is done under the aegis of Navodaya Cancer Hospital and Research Center at Bhopal, and it's a great pleasure to welcome the organizing secretary, Dr. Shyam Agrawal. Good evening, Dr. Shyam Agrawal, sir. Sir
Yeah,
needs
good
no
evening, Dr. Tarun.
introductions.
Good evening. Yeah.
Yes, sir is a senior consultant medical oncologist at Navodaya Hospital, Bhopal. Sir will bless us with his welcome and introductory note. Sir, over to you for your opening remarks and setting the context, please. Over to
Yeah.
you, sir.
Good evening, everyone, and thank you very much, Tarun, for nice words. And I would like to say good afternoon to Dr. Mark David Vincent, because I think London must be around, say, 12 o'clock this time. So we all welcome you on this very interesting and exciting live international webinar on recent updates on lung cancer. So if I give a kind of brief of this program, we have 2.5 hours program. The first half is dedicated to the small cell lung cancer, and the later one to the non-small cell lung cancer. In both these sessions, we have two presentations rather, and followed by case-based discussion to know what is the real-world scenario in lung cancer. And Dr. Mark David will speak on management of stage 3 lung cancer. What is the evidence and experience so far? Then at the last, we have a presentation on ALK positive non-small cell lung cancer. That is also the need of the hour today. So in short, it covers most of the topics of the lung cancers need to be updated today by all the medical oncologists as well as the radiation oncologists. And we have galaxy of eminent speakers and oncologists today from all over the country. And of course, from the London, Dr. Mark Vincent is also presenting his experience and evidences. So it's going to be really very exciting academic feast today. So with that words, I open the inning, and I would like to present the newer advances on the lung cancer diagnosis. Can I have my slides, please? Yeah, thank you very much, Surbi. So as we know, most of the index, please. Most of the cancers, lung cancers overall is diagnosed in very, very late stages, and approximately 70 to 80% of the lung cancer also diagnosed in very advanced stages. This is what the burden of lung cancer in Globocon study, where we have, if we count both the sexes, male and female, the lung cancer, the blue part of this chart is showing around fourth on the location is around 72,510. This is around 5.5% of the overall lung cancer burden. But if we see the male patients only, it is on the number 2, next to the lips and oral cavity part. Next, please. So it is the second most common cause in males and the fourth overall. Next, please. And this is what the incidence, mortality, and prevalences by cancer site. And if we see the lung cancer, it is at the 4th rank overall in the new cases. And if we see the deaths are also at the 4th level, it is, if we see the incidence in new cases around 72,000, then the death is around 66,000. That is more than 80% of the cases we diagnose. So what is, next please, what is the cause of this? Because majority of the patient, as I said earlier, the 75% of the patient of non-small cell lung cancer are diagnosed in the very, very late stages. So you see the globally stage 1 and 2 are very, small part of the detected cases. Next, please. So this is what the resectability is very, very prime importance if you want to achieve a cure. Next, please. but we received only 25% around early cases, but 75% of the cases came to us with the unresectable disease, pleural effusions, supraclavicular nodes, and bilateral metastasis. Next, please. In India also, we have only fewer patients are diagnosed in very, very early stages, because we don't have a proper screening program. We don't have the higher index of suspicion in patients. So here it is around, only 3.5% of the patients in the stage 1 and 2. And if it see this 3A stage, only around 13%. But all other cases or beyond the salvageable stage. And if we see the stage 4, it is more than 50%. That is really alarming and kind of very difficult to treat patients. Next, please. Next. This is what the AJCC 8th edition has come with. There were some modifications with the coming some stages, like the T size and nodal size they have met, but still it is only for the academic exercises. Next, please. What we are more interested into the why the lung cancer is diagnosed in the later stages. So we have found in India, especially, the diagnosis is not done properly on time. There is lacking the screening program in high-risk patients and lack of awareness among the patients also. The most of the smokers, they don't want to leave smoking and they say, "Mujhe to cancer ho hi nahi sakta," kind of. Next, please. So this is what the scenario in India. And if we see the patient with warning signals and symptoms also, lung cancer was misdiagnosed as tuberculosis. This is the very well depicted in the next slide. Not only in the few stages, but almost all these states have the misdiagnosis, and they somehow physicians, they have tendency to start tuberculosis treatment, because we know that tuberculosis is rampant in India. There are more number of cases. So just by hitting by anti-tubercular treatment, they might be getting some results, but most of the patients, they misdiagnose and they land up in very advanced stages. So this study was conducted in AIMS in diagnosed patients with CA lung cancer, and this is what the around 20% of the cases they misdiagnose, and their survival goes to less than 4 months. Next, please. And again, we have seen the Vellore, Tamil Nadu, Karnataka, Uttarakhand, Jammu, Madhya Pradesh, and New Delhi. There are a lot of studies, and they have shown the symptom to diagnosis delay is beyond 3 months, minimum 3 months. And then the mortality goes high. And this is the evidence that in India, we misdiagnose lung cancer as tuberculosis almost all over the country. Next, please. So what is the screening techniques? We have few modalities. Next, chest X-ray. We have sputum. Next, we have low-dose CT scan. Chest X-ray and sputum cytology is not recommended. It is not adding or not giving benefit to the life save. But low-dose CT scan, yes, this is all evidence-based. Now, let's learn something about what is low-dose CT scan. Next, please. This is what the majority of lung nodules are incidentally detected if we do low-dose CT scan for, either patient comes for the trauma or cardiac symptoms or abdominal symptoms. Incidentally, we detect around 62% of the incidental lung nodules. And the remaining screening, if we do in certain areas, only 13% cases are detected on screening. So basically, what we receive or we diagnose in most of the cases, the incidental lung nodules, by doing CT scan for some other regions, not specifically for the purpose of doing screening. Next. So this is what the low dose CT scan. Normally, the conventional X-ray exposure in a CT scan is around 115 milliamperes, but in low dose CT scan we do 40 to try to achieve around 25 or 40 milliamperes, and it gives satisfactory image quality and it reduces the CT dose index, thereby maximally protects patients from radiation exposure, because we need to do it again and again if the nodules are there in a high risk or the follow-up kind of issues. Hence preferred for multiple scans as needed for the high risk patients. Next, please. Next, please. So there are recommendation to existing lung cancer screening guidelines, and this is what the 2021 USPSTF lung cancer screening guideline, the new frontier. And next, please. So that is what they have said that next, please. That it is estimated that the increase in screening under the new guidelines could save around 10,000 to 20,000 lives each year. So, however, up to 45% of lung cancer in former smoker occur more than 15 years. Like if somebody has quit the smoking, and after 15 years also you can find the lung cancer or the nodules. So they are revising the guidelines by removing the 15-year rules, and would now more patients can have the screening even after giving up the smoking of 15 years or beyond. Next, please. So this is what we can save 10,000 to 20,000 lives per year if we do proper screening. Next, please. Incidental pulmonary nodule detection and follow-up will increase. So most likely what happens in our country, like we do CT scan, we diagnose incidental pulmonary nodules, but the follow-up is less likely. Next, please. So next, are we following the lung nodules regularly as per the guidelines? I don't think, because you see that there's a nodule and you just say, okay, we'll observe it or something like that. But there are definite guidelines, and if you follow these guidelines, it can be adequate follow-up, and you can pick up more lung cancers, 3 to 5% of all almost, because not all the lung nodules are cancerous, but what are the suspicion and how we have to diagnose, this is what the guidelines are coming up. Next, please. And this is the multiple guidelines. We have Fishner Society, we have NCCN guidelines, we have American College of Radiology guidelines, we have American College of Chest Physician guidelines, and we have British Thoracic guidelines. And every few years they update it with the high risk factors or the size of the nodules and so many other things like exposure to different pollutants or the occupational hazards. So there are many guidelines, and they prefer with the malignancy risk assessment and the patient preference in the identifying the early lung cancers. Next, please. This is the Fishner Society 2017 guidelines for management of IPN, and this informs management of patients of more than 35 years of age. They are non-immunocompromised and those with without a known malignancy. So there have been factors to divide the risk assessments, like there are solid lung nodules and subsolid lung nodules, and then what is the size of the nodule, what are the risk features, the low risk or high risk, if they are smoking, the number of smoking years, then how to follow up, the first follow-up and second follow-up, how frequently we should do. These are the Fishner guidelines flow chart. Next, please. And this is what they have said. Approximately 2 out of 3 patients with IPN receive no clinical follow-up. That's what we are discussing. We diagnose, but we don't have a follow-up. And almost no patient follow-up has been observed with incidental nodules are mentioned only in the finding section on the radiology report, but they are not followed, like 0%. In one large study, the mean time from initial diagnosis to a pulmonary nodule to first workup was 8 months, minimum 8 months for the average mean time. So these are the bars. They're showing that the mortality percentage of patients requiring follow-up is around say 70%, but only follow-up was given only 30% of the patient. Next, please. And this is what the outcome. This is what the benefit we get. If we do a regular follow-up and do low-dose CT scan screening, the mortality is reduced up to 20%. There's relative reduction in mortality of 20% with the confidence interval of 95%. So you can see the graphs, like in a lung cancer patient, low-dose CT scan, the graphs are wide apart compared to the only chest X-ray. And deaths also, if you see the low-dose CT scan, lower black line is much lower than the what you are following on the chest radiograph or the X-ray. So CT scan is much better, not only in detection, but also reducing the mortality of it. Next, please. This is what they've said. The company, they've compared with the other screening organs. Like if you do colorectal cancer, one life saved, you need 864 tests. And for breast cancer also, which is so common, you need 645 to 1700 scans to save one life from breast cancer. But in lung cancer, if you do only 320 low-dose CT scans, you can save one life. So it is really kind of cost effective and life benefit effective screening for the lung cancer. Next, please.
Sir, you have a minute to conclude, please. Last one.
Okay.
Please.
So we have seen that the screening is important. We have seen the mortality and the detection is much better. And now we have to, divide the patient in the high risk and low risk patients and how frequently we should do. Next, please. This is what the screening group is showing, much less lung cancer mortality. Next, please. Next, that we have already discussed. These are the screening guidelines. As we said, there are a lot of risk factors: the smoking, the occupational exposure, the family history. Next, please. This is what the diameter of the nodule, if it is 5 millimeter or smaller, follow between 12 months. And accordingly, if it is more than 15 mm, you have to do PET scan and do biopsy. Next, please. So, what are the issues? What are the challenges? There's no screening guidelines for the non-smokers. We see around 15 to 20% of the patients coming from the non-smoker group. But we have no screening guidelines for the non-smokers, and it is not as cost effective in India. So that's why they say it is a costly affair. Next, please. Next. We need a multidisciplinary approach, multidisciplinary team to decide about the IPN biopsy or how to go ahead with them. Next, please. So these are what the different guidelines showing when to do EBUS, when to do PET scan, when to follow, when not to follow. Next, please. Next. These are the ESMO guidelines that they always assess the lung functions, the coagulation profile, and the heart assessment also before going for the lung biopsy. Next, please. Next, please. These are the NCCN guidelines divided into two incidental findings. The solid lung nodule, they have got different guidelines for the low risk and high risk. Next. And if they find the subsolid nodules, then again they have different criteria for the follow-up as well as doing a biopsy. Next, please. This is what they have said. If you don't found a lung nodule and if you want to excise it, when to do biopsy, when not to do biopsy is very fine depiction of how to go for the diagnostic workup, when to do bronchoscopy, when to do mediastinoscopy. This all has been very well depicted here. Next, please. So to conclude, like earlier the diagnosis, earlier the lung cancer detection, better is the survival. And you see the extreme left, the stage 1A, and the extreme right, only 10% survival. Next, please. So that is what in summary we have already said. Earlier the diagnosis, earlier better is the outcome. And there have been there are challenges in the screening in India for the non-smoker. The cost is the problem. But still, if you want to save the patients, that is the 10,000 to 20,000 lives per year, then screening is the modality. Next, please. So thank you very much. And with that, I finish my
thank you, sir.
talk. Thank you very much.
Yes, sir. Thank you. So thank you, Dr. Shyam, sir, for such a wonderful presentations on diagnosis. We can have the question and answer into the chat box.
Yes.
We move to that. We move to the next speaker, and this is none other than Dr. Shrikant Tiwari. Good evening, Dr. Shrikant, sir. He's a consultant medical oncologist at prestigious Jawaharlal Nehru Cancer Hospital and Research Center in Bhopal. And Dr. Shrikant will talk on concurrent chemoradiotherapy versus sequential CRT, pros and cons. So good evening, Dr. Shrikant, sir. You need to, you need to start your presentations.
Good evening, everyone. Let me just share my screen. Is my screen visible now?
Yes, Doctor Shrikant is visible. You have to make it in a full mode.
I'm making it, sir. I'm making it, sir.
Okay.
Yes. So thank you, Shyam Agrawal, sir, for this organizing this an important session on the lung cancer, and thank you AstraZeneca for sponsoring this academic feast. So my topic for the discussion is whether the concurrent CTRT or sequential CTRT or induction chemotherapy followed by CTRT, what should be the better choice in stage 3 lung cancer where the disease is inoperable. So the stage 3 is a highly heterogeneous group, and the treatment for all these different groups are different, and it's all depend upon what is the subgroup of stage 3 and what is the general condition of the patients. The treatment options which are included in stage 3, it includes surgery, chemotherapy, radiotherapy, immunotherapy, or the combination of these 2 or 3, depend upon the disease presentations, I mean the subgroup of the patients as well as the performance status of the patients. The most common presentation in stage 3 NSCLC, although in stage 3 NSCLC, it includes stage 3A, B, and C. And there are multiple subgroups in stage 3A, 3B, and 3C. But the most common presentations are in stage 3A, where the ipsilateral mediastinal nodes are involvement, that is N2 nodes are involvement. And in stage 3B, where the contralateral mediastinal nodes are involved, that is the N3 nodes are involved. So this is the diagrammatic presentations. If you see the heterogeneity with in stage 3, so in one bracket is stage 3A, where the most common presentation is the tumor size is either T1, T2 with N2 nodes, or sometimes T3 and T4, whereas with N1 nodes. This T3 and T4 with N1 nodes or T4 with N0 nodes, these are the candidate of the surgical modalities. Otherwise, T1, T2 with N2 nodes, they are in stage 3B if the T3, T4 with N2 nodes, or T1, T2 with the N3 nodes. These are the most common inoperable stage 3 subgroup of patients, where the treatment modality will be either concurrent chemotherapy, radiotherapy, or induction chemotherapy, sequencing the chemotherapy followed by chemotherapy and radiotherapy. So if you see, this is the 8th edition of AJCC TNM staging, and if you see the this whole arena of this TNM bracket, so most heterogeneous group is a stage 3A, which includes, if you see, almost 60 to 70% of this bracket is covered by a stage 3. That indicates how the heterogeneous is stage 3A. And if you talk about the 5-year survival, where in stage 1 and 2, the 5-year survival is ranging from 60% to 90%. But if you come to a stage 3, I'm not talking about a stage 4. In a stage 3, the 5-year survival is ranging from 10% to 40%. So if in a stage 3, the prognosis is not very good, except in a stage 3A, where the prognosis is still good, up to 40%. So 5-year survival is up to 40%. So this stage 3B and 3C is a very important bracket, where most of the patients lies, and the 5-year survival is almost dismal 10 to 20%. So this is the overview of current treatment guidelines of the NSCLC. In stage 1, the treatment is most of the time treatment is surgery. If surgery is not possible due to general condition of the patients, then targeted radiation can be an option. In stage 2, the treatment will be surgery followed by adjuvant chemotherapy plus minus post-operative radiotherapy if required. In stage 3, although it is a very heterogeneous group of disorder, the treatment will be surgery or neoadjuvant chemotherapy followed by surgery plus minus followed by radiotherapy, or concurrent chemoradiotherapy. If patient is inoperable, then concurrent chemoradiotherapy followed by plus minus consultation with the immunotherapy. In stage 4, we all know the treatment will be either chemotherapy, targeted therapy, immunotherapy, or sometimes the patients present in such a frail condition that we cannot offer the treatment and put patient on the best supportive care also. So what should be the reasonable option of the treatment in stage 3 patients? So the one option is the concurrent chemoradiotherapy. So chemotherapy will continue along with the thoracic radiotherapy. And the second option will be the induction chemotherapy, the sequencing of therapy, that the first neoadjuvant chemotherapy to downgrade the tumor, and then concurrent chemotherapy and radiotherapy is given. Initially, there was one other modalities, was the concurrent chemotherapy followed by the consolidation chemotherapy, but it has been seen in the data that the therapy was not beneficial to the patients. So now in stage 3 inoperable patients, there are two treatment modality available. So there is concurrent chemoradiotherapy or sequential chemotherapy followed by chemotherapy and radiotherapy. So these are the certain meta-analysis which will say which modality of therapy, whether the concurrent chemotherapy, radiotherapy, or sequencing of therapy will be better. So there are three meta-analysis. The first meta-analysis where they have included 22 trials, and the arms were the sequential chemotherapy, radiotherapy versus radiotherapy alone. The number of patients were 3,839. And if you see the 3-year absolute benefit at 3 years is around 2.6% with hazard ratio of 0.88. In the second meta-analysis, again, the concurrent, they have taken the concurrent chemotherapy. In first meta-analysis, they have sequential chemotherapy, radiotherapy versus radiotherapy alone. And in second, they have taken concurrent CTRT versus RT alone. Again, the absolute benefit at 3 years is around 3.2% with a hazard ratio of around 0.88. The third important meta-analysis, which has head-to-head comparison of concurrent CTRT versus sequential CTRT, the 6 trials have been included, and it has been seen that absolute benefit at 3 years is around 5.7% in favor of concurrent CTRT. So if you elaborate the final data of this last meta-analysis, it is seen that those patients who were on the concurrent CTRT, there was increase in overall survival with the p-value of 0.004, which is significant. The PFS was also better, and the risk of loco-regional progression was reduced. Although there was no difference in the rate of distant progression in seen whether the patient is on concurrent chemotherapy versus sequencing of chemotherapy followed by radiotherapy. The adverse effect, the acute esophageal toxicity is increased in those patients who are on concurrent chemotherapy, radiotherapy versus those on the sequencing. The range is from 4 to 18%, but there is no difference in the pulmonary toxicity. So the only adverse effect we can see in
My apologies, sir. You are just left with 1 minute to conclude your presentation. Thank you.
Okay. So there was no differences in the acute pulmonary toxicity was seen. So this is the same data, the one institutional data of which compare the sequencing versus concurrent CTRT, and the outcome with the sequential CTRT was in median overall survival was around 17.4 months, and 5-year survival was around 17%. Whereas in those patients who have on concurrent CTRT, the median OS was around 18.6 months versus the 5-year survival was around 19 months. The meta-analysis of this 6 randomized trial, the overall survival in sequential CTRTs, 3-year overall survival is around 23%, whereas the 5-year overall survival are around 15.1% in concurrent CTRT. The similar data is also seen with the in the PFS. So this is the again the same meta-analysis of these 6 trials, and all this data shows that the concurrent CTRT has better improvement and better survival, better progression-free survival, and better overall survival if you compared with the sequential CTRT in stage 3 inoperable lung cancer patients. This is the another trials. The concurrent chemotherapy has been the standard of care for those patients who are on unresectable stage 3 lung cancers. I'm not going in the detail of these trials. The one is the URCT trials and these different trials, and they have used different chemotherapy regime, weekly chemotherapy versus daily chemotherapy, hyperfractionated thoracic radiation given. And if you see those patients who are on only radiotherapy versus radiotherapy plus chemotherapy, the outcome at 3 and 4 years is 23% in CTRT group versus only 9% in RT group. So in stage 3 unresectable NSCLC, the CTRT, if you see in 3 to 4 years period, the cure rate is around 20 to 25% if you compare with the RT alone. Next, these are the chemotherapy drugs which are using, it can be cisplatin, carboplatin, or the pemetrexed. We can use paclitaxel along with the carboplatin. So we can use single agent or multiple agent as a chemotherapy along with the radiotherapy. So this is the conventional dose which are using in radiotherapy, whether it is the post-operative radiotherapy or pre-operative radiotherapy or CTRT or palliative radiotherapy. I'm not going in detail of this, the dose of the radiotherapy. The toxicity, as I have already said, those patients who are concurrent chemoradiotherapy, if you compare the toxicity versus radiotherapy or versus radiotherapy and sequencing radiotherapy and chemotherapy, the acute esophageal toxicity is more commonly seen in those patients who are on concurrent CTRT versus in sequencing. Other toxicity are almost same. So what other even if you see after the in stage 3 unresectable NSCLC, even in with the concurrent CTRT, the 5-year survival is around 10 to 20%. So what more can be done? There are multiple strategy has been tried without any success. That is the incorporation of newer chemotherapy drugs, use of induction consolidation strategy, incorporation of targeted therapy like cetuximab, the vaccine strategy, dose escalation of RT. And if you see with all this data of this either increasing the dose or use of chemotherapy, there was no increase in the survival. So in summary, stage 3 locally advanced NSCLC, I have already discussed how heterogeneous is the disease, and the treatment in unresectable stage 3 NSCLC is the CTRT. Until unless the patient is frail and patient cannot tolerate CTRT directly, then we can do sequencing. Advanced RT technique has led to the safer and more efficacious treatment in those patients having stage 3 NSCLC. Yet, according to registry data, 50% or fewer of those patients receiving concurrent CTRT. All eligible patients with stage 3 NSCLC should receive concurrent CTRT. Thank you.
Thank you, sir. for the wonderful presentation. Next, we move on to, I would like to invite Dr. Sameer Srirangawar, who is Consultant Medical Oncologist, National Cancer Institute, Nagpur, and he's going to talk on experience sharing on durvalumab in first-line ES SCLC. Over to you, sir.
Am I audible?
Sir.
Hello. Am I audible?
Yes,
Am I
sir,
audible?
you are audible and your screen is visible.
Visible. No?
Yeah.
Okay. So thank you, AstraZeneca, and thank you, organizers, for giving me this opportunity. The topic which I will discuss today is role of durvalumab in the management of extensive stage small cell lung cancer. Next slide. So I will start with the case here first. So my patient is Mr. X. He is a 34-year-old gentleman. He presented in June 2020 with a complaint of change in voice, which was slowly progressed to aphonia and dysphonia. He had a known comorbidities. He was a chronic smoker. Because of his complaint of change in voice, he visited to ENT doctor first, where he was diagnosed to have vocal cord palsy. After that, he underwent a CT scan of head and neck and chest. Next slide. So his CT scan showed a small soft tissue lesion in the apical segment of the left lung, and there were multiple conglomerate necrotic mediastinal lymph node. Next slide. So on the basis of these findings of lung nodule with multiple necrotic lymph node in the mediastinum, he was started on anti-tubercular therapy empirically by the general practitioner. But as expected, he didn't respond to that anti-tubercular therapy. His condition progressively worsened. And in the next month, that is in September 2020, he developed one episode of seizure, after which he was started on anti-epileptic drugs and a brain MRI was ordered. Next slide. So a brain MRI showed a 2 centimeter lesion in the right temporal lobe with a mild surrounding edema. And there were also multiple sub-centimeter size lesion in the bilateral temporal, frontoparietal and occipital lobe. Next slide. His CT thorax was also done again at the same time, which showed there is a SOL in the left upper lobe of the lung with a mediastinal extension and the mediastinal lymph nodes. Next slide. So this was a PET scan done at the same time. So here we can see in the PET scan images, there was a large left upper lobe lung mass with the mediastinal extension with a mediastinal lymphadenopathy. Next slide. Here we can see the clearly bone mets were present, even lymph node mets, and there was brain mets also present. Next slide. So further, he was investigated with the biopsy, which showed small cell neuroendocrine carcinoma, and his PDL1 TPS score was 3 to 4%. Next slide. So final diagnosis was extensive stage small cell lung carcinoma with brain metastasis. Next slide. So in such cases, what should be the next step? Whether a patient should be treated with radiotherapy first, followed by systemic therapy, or patient should be straight away started on chemotherapy, or patient should be treated with chemoimmunotherapy in a patient with metastatic and brain mets positive small cell lung cancer, extensive stage small cell lung cancer. Next slide. So what are the consensus for treating brain metastasis in patient with extensive stage small cell lung cancer? So this paper was published in August 2020 in Radiotherapy and Oncology journal. This was decision making among the multidisciplinary panel of European experts regarding the management of brain metastasis in extensive stage small cell lung cancer. So what was the key conclusion of this study? So what they've said, if the patient is asymptomatic, chemotherapy alone is most commonly recommended first-line treatment. Even if the brain metastasis volume is limited, if the patient is asymptomatic, higher preference should be given to the chemotherapy rather than the radiotherapy. But if the patient is symptomatic, you should start with the radiotherapy and chemotherapy should be started along with it or later on. And if the patient is symptomatic and the brain metastasis is of limited volume or a single metastasis there, some suggestion was that we can go ahead with SBRT rather than WBRT, and systemic therapy should be given as with any other patient with extensive stage small cell lung cancer. Next slide. So these are the NCCN guidelines. NCCN also says the same thing. That is, if the patient is having extensive stage small cell lung cancer with a brain metastasis, if the patient is asymptomatic, systemic therapy may be given before the radiotherapy, But if the patient is symptomatic, then the radiation should be started before the chemotherapy. Next slide. So what are the options for chemotherapy in extensive stage small cell lung cancer? So since last almost 3 decades, it's like 30 years time, etoposide and platinum combination has been the standard of care. And here in this slide, we can see this chemotherapy has been compared with various other historical regimen. And here we can see the historical regimen has been different in different trials. But in all these trials, etoposide platinum combination was the better combination. And here we can see the data for this regimen in these trials. So in various these trials, overall response rate varied from 50 to 70%. In some cases, it is reaching up to the 80%. Median PFS ranged from 4 to 5 months, and median OS ranged from only 9 to 10 months. So this data clearly shows that the outcome of this patient is very minimal and dismal, and we need to have a newer, better regimen to improve the outcome of this poor prognosis extensive stage small cell lung cancer patient. Next slide. So with this data, the means like standard regimen, patient was started on chemotherapy with etoposide cisplatin. In November, he was also given hippocampal sparing WBRT because of his brain metastasis. Next slide. But what's new in 2021 now for us? So these are the NCCN latest guidelines. So here we can see the guideline has changed, and now the NCCN guideline has included the immunotherapy plus chemotherapy, that is chemoimmunotherapy combination for the management of first line therapy of extensive stage small cell lung cancer. And the NCCN guideline mentioned both atezolizumab and the durvalumab regimen is category 1 for all patients. Next slide. So with this recommendation and with this data, this patient was started on durvalumab from the 3rd cycle of chemotherapy, and after 4th cycle, he was started on maintenance. Next slide. So now this what happened to this patient we'll discuss later on. Now I will discuss the role of immunotherapy in small cell lung cancer and what is the rationale of combining chemotherapy and immunotherapy here. So whenever we give chemotherapy to any solid tumor patient or any, like here we are discussing small cell lung cancer patient. So whenever you give chemotherapy to this patient, the tumor cell killing causes induction of exposure of tumor antigen, and that is tumor antigen release. So this tumor antigen which is released after the killing of tumor cells because of chemotherapy, it is exposed to the immune system. But what happens when there is a PD-L1 overexpression? This leads to the immune cell invasion and T cell inhibition. So even if the new antigen has been released, but the T cell doesn't act because they are inhibited because of PD-L1 overexpression. So if we can block this PD-1 and PD-L1 interaction, that this inhibition can restore the T cell specific immunity, and this reversal of immune suppression can lead to a deeper, more durable, and more better systemic anti-tumor responses. So this is the rationale of combining chemotherapy and immunotherapy. Next slide. So I will discuss here the Caspian data. So this is a slide showing schema of this trial. Here we can see how in this trial, the newly diagnosed extensive stage small cell lung cancer patient, the inclusion criteria was performance status 1, life expectancy more than 3 months, at least one target lesion as per the RECIST 1.1, and this patient's newly diagnosed patient were randomized to receive, were randomized into 3 arms. That is, patient received a combination of immunotherapy with etoposide platinum compound with durvalumab, or they received only etoposide platinum compound, or the third arm actually included durvalumab plus chemotherapy plus the second immunotherapy agent, that is tremelimumab, that is the anti-CTLA4 agent. So in this trial, the primary endpoint was overall survival, and the secondary endpoint was PFS, OS at 18 months, overall response rate, and even health-related quality of life. Next slide. So actually, I already showed that NCCN slide. So NCCN has included both the option, that is atezolizumab and the durvalumab, because we have data for both. So atezolizumab was studied in this similar setting in IMpower 133 trial, but and the Caspian was durvalumab trial. But there are some basic study design differentiation in these two trials. So this is a slide which shows what are the differences, basic study design differences between these two trials. So in both the trial, all comer patients were included. That is, there was no biomarker for the selection of this patient. But if you see here, in the atezolizumab trial, the untreated brain metastasis patients were excluded. Only Caspian included the brain metastasis patient. PCI was included in PCI in control arm was allowed in both the trials, but PCI, that is prophylactic renal irradiation, was allowed in experimental arm only in atezolizumab trial, but it was excluded in the Caspian trial. Up to 6 cycles of chemo in the control arm was allowed in only Caspian trial, but not in IMPOR 133 trial. And the choice of platinum, that is cisplatin, was allowed only in the Caspian trial, but not in atezolizumab trial. So these are the minor differences, but this differences shows that the Caspian study inclusion criteria is reflective of real world clinical practice. So next slide. Next slide. So again, here I will highlight some of the important aspects of Caspian trial. So
my apologies, sir. You are just left with 2 minutes to conclude your presentation. Thank you.
So Caspian trial had etoposide platinum combination with durvalumab for first 4-cycle induction followed by durvalumab maintenance. So Caspian allowed the choice of platinum, that is cisplatin, either carboplatin. It allowed the 6 cycles of chemotherapy in the control arm, and it also PCA was offered only in the control arm and not in the durvalumab maintenance arm. So all these findings, that is allowing the 6 cycles of chemotherapy, allowing the platinum, either cisplatin, carboplatin, and optional PCI. So these all indicate that it is like in line with our routine clinical practice, which we treat, which the way which we treat this patient in our routine clinical practice in day-to-day real world clinical scenario. Next slide. So now I will discuss the efficacy data. Here we can see the OS was better in durvalumab arm as compared to chemo alone arm here in both patients, that is in patients with brain metastasis or even without brain metastasis, with the clear-cut separation of curves here in both the patient, that is brain mets present or not present. So that means durvalumab is giving benefit even in presence of brain metastasis as compared to the chemotherapy. Next slide. So this is the PFS data. Here we can see at 12 month, 18 month, and 24 month data cutoff, the PFS was better with durvalumab plus chemo combination as compared to the chemo alone arm, and almost more than 4 times the number of patients were progression free at 24 months with the immunotherapy combination as compared to the chemo alone. Next slide. So this is the OS data. Here we can see OS was also significantly better with durvalumab plus chemo as compared to the chemo alone. At 3-year cutoff, the OS was 17.6 months with immunotherapy plus chemo combination as compared to the chemo alone, with a hazard ratio of 0.71. So here we can see almost immunotherapy 3 times the more number of patients were alive at 3 years as compared to the chemo alone arm. Next slide. So even in subgroup analysis, almost all the category of patient had benefited with the immunotherapy combination. So irrespective of the platinum compound, irrespective of the age, sex, performance status, irrespective of the brain metastasis, smoking status. So every group of patient benefited more with the addition of durvalumab to the chemotherapy. Next slide. So even overall response rate was better with durvalumab plus chemo as compared to the chemo alone, and even the median duration of response was better. Here we can see at 12 months there was a clear-cut separation of curves, and there were more long-term responders in durvalumab plus chemo. Next slide. So this is the same thing, I think. Next slide. So now what happened to our patient? So this patient received the 3 cycles of maintenance immunotherapy after completion of induction, and the follow-up PET scan was done. Next slide. So here you can see how the patient has beautifully responded, and the lung mass almost completely gone, and there was disturbance of all bone metastasis, and even brain mets responded. Next slide. And that's why the patient was continued on maintenance durvalumab for almost 10 completion of 10 more cycles. And again a PET scan was done. Next slide. So at follow-up PET scan, after 10 cycles of immunotherapy, there was an ongoing response, and there was a further decrease in the size of the lesion in the both brain and the primary sites. And there was no new lesion, active lesion anywhere else in the body. Next slide. So what is the advantage of durvalumab here as compared to the atezolizumab? So durvalumab here, the maintenance was given 4 weekly. So in the atezolizumab, the maintenance was given 3 weekly. So here it is 4 weekly. So that is more comfortable for the patient. And this 4 weekly maintenance also decreases the number of hospital visits during the maintenance phase. So that is comfortable for both patients and the even physician, because it decreases the number of hospital visits for the patient. Next slide. So what are the conclusion of this trial? Durvalumab plus chemotherapy is a new standard of care, definitely in the first line extensive stage small cell lung cancer. So this first line combination has shown a sustained improvement in the OS as compared to the control arm. And this control arm was reflective of the real world clinical scenario, which allows the 6 cycles of chemotherapy, allow the PCI in a control arm, which was not in the atezolizumab study. Durvalumab is the only IO which allows the flexibility of choosing the platinum partner here. We can use either a cisplatin or carboplatin. Benefit was observed across all subgroups, including the brain metastasis patient. More than 17% of the patients were surviving even after 3 years, which is really a commendable outcome, because we hardly see any patient surviving up to 3 years in extensive stage small cell lung cancer, which shows the prolonged survival benefit definitely. Some patient may have a prolonged survival with this combination. It also gives a high response rate, which will definitely give us a more symptomatic benefit also. And it offers a convenient monthly maintenance dosing, which is actually very comfortable for the patient also. Safety findings here are consistent with the whatever known safety profile with durvalumab regimen with any combination chemotherapy. Next slide. Next slide. I will end here. Thank you.
Thank you so much, Doctor, for the excellent presentation. And now we move to the case-based panel discussion on optimal management of first-line SCLC. And for this, I would like to invite our moderator of today, Dr. M. Basri, who is Senior Consultant Medical Oncologist, Cephi Hospital, Mumbai. Over to you, sir, for the panel discussion.
Thank you. Thank you very much, and hope you are able to listen to me. Should I share my screen?
Yes.
Okay. So you can see the slides now. Okay,
yes.
So let me invite my panelists, Dr. Nikhil Pandey. Samir was obviously there just now. Dr. Rajesh Patidar, Reshma Puranik, and Srikant Tiwari. I think 2 names have been dropped: Bhupesh Guleria and Siddharth Turkar. Are they there? Hello?
Yes, sir.
I am here, sir.
Yeah. Sorry. I mean, in virtual it is difficult whether are you there or no. Okay, so let's go ahead. I think Samir has wonderfully covered all the slides what I'm going to show, but let's have a practical discussion on all those slides. We will have that. So here is another case, 62-year-old. He is a current smoker who has heavily been smoking, presented with the shortness of breath, hemoptysis, weight loss, and early satiety. And there was also a massive hepatomegaly. Okay, so with that, and there were liver enzymes were high. So with that, the patient had gone to the doctor and he did the further investigation. So let me start with Nikhil. If somebody comes to you with a suspected malignancy of lung because of shortness of breath, hemoptysis, weight loss, so what are the list of investigations will you start?
So sorry, sir. Nikhil sir is not joined yet. He will join in a couple of minutes.
Rajesh Patidar. You are mute.
Yes, sir. Yes, sir. So if this kind of patient comes to me in OPD, first of all, I'll get X-ray done, and and X-ray and sonography. And if in that some mass is there in lung, then I go ahead with the standard lung cancer staging system and biopsy.
Okay.
So first investigation I do in this kind of patient is chest X-ray and sonography.
Okay.
And
So you will do the other investigations like CT and PET after the biopsy, or
I didn't get, sir.
or before you want?
I didn't get what you asked, sir.
No, what I mean to say, you said X-ray and sonography.
Yes,
When
sir.
will you do the CT scan or?
So in yes, if in X-ray some lesion is there, or in sonography some lesion is there, then I will go ahead with the CT scan. And if mass is there, I will go ahead with the biopsy, whether image guided or bronchoscopy, whatever the CT scanner suggest.
Okay. Okay, okay. So let's go ahead to the next. Reshma, whenever
Yes, sir.
you do the biopsy, what kind of biopsy you ask for?
Sir,
Preferably lung guided, lung CT guided lung biopsy or bronchoscopy, or how?
sir, the biopsy which I ask for depends on the location of the tumor. If it's a perihilar mass or a hilar mass, then a bronchoscopic biopsy is what I insist. But if it is a peripheral mass, then it is a CT guided biopsy that we ask for. So
Okay.
this, yes, sir.
So at the outset, you will not know whether the patient is having small cell or non-small cell.
Yes. Sir.
So you collect the sample for molecular markers this time only, or how do you do that?
Yes, sir. We generally insist to get a good chunk of tissue so that in case we would want to do the further studies, the tissue is adequate for the NGS testing also. So we have a collection of good chunk of tissue in the beginning itself.
Okay. So here NCCN recommends few, initial evaluation apart from biopsy and pathology review, CBC, electrolyte liver function test. Do you do anything other than this? Reshma?
Sir, in a suspected small cell lung carcinoma, I think we should also look for the TLS profile, uric acid and other TLS profile
Yes.
markers also should be checked.
Exactly. That is what I actually was trying to look for it. And we usually do that, calcium and uric acid and other issues. Those are also very important because there could be massive tumor lysis which can happen with that. Yes, so the patient has so there is one message coming on my window. Please move this window away. What does that mean? Anybody, organizers? Okay. So the next, what happened with this patient, that CT scan showed there was a left lower lobe mass and with mediastinal adenopathy and massive hepatomegaly. So the lung biopsy showed it's a small cell lung cancer. The CT guided liver biopsy also confirmed there is a metastatic involvement. And they also did the MRI brain, there were no abnormalities. Samir, you rightly mentioned that if somebody has got the brain metastasis and patient is asymptomatic, then you go ahead with the systemic therapy, right?
Yes, sir. Yes. The
And
patient
the
is asymptomatic.
other was patient is symptomatic, then you should go ahead with the radiation first.
Right, sir. Right.
There is one in between. If suppose somebody has got, say, massive pleural effusion, pericardial effusion, large SVC obstruction, and the brain mets. So what will you do now? If you go on treating brain mets, then patient will not be able to lie down also for the brain mets.
So you mean to say, sir, patient is symptomatic for brain mets in this case?
Symptomatic for lung cancer also and brain also.
Brain also. So in such cases where we want patient is not stable, so in such cases I will start with the chemotherapy definitely.
Okay, so that is a one small, if you read the NCCN, which I will show you also over a good period of time, that if the systemic therapy is required because of the tumor which is rapidly progressing, or there is an SVC obstruction or pericardial effusion and pleural effusion rapidly filling up, then one should go ahead with the systemic therapy. It's not all the time symptomatic. If somebody has got headache, that means you have to go and irradiate also for that patient. So that's the important one. Okay, Srikant, tell me, what is your first choice of platinum? What you prefer, cisplatin, carboplatin, and why?
my choice will depend upon the age of patients and the performance status of the patient. If the patient is a younger age group, because the performance status is good, although most of the time we see in clinic that when the patient presents, the performance status is not good. So in good performance status, I will go with this cisplatin based chemotherapy.
Okay. Okay. And how many cycles do you use? 4 cycles or 6 cycles?
Sir, we use 4 cycle, and then sir, hello.
We are able to listen in between to you.
Are you hearing me now?
Yeah, very slowly.
Oh, actually, there was. Now, are you getting
Yes,
my
yes. Go
voice?
ahead. Go ahead. Go
Okay.
ahead.
Yeah. So we usually use 4 cycle chemotherapy, sir, and then we go for evaluation to see how the patient is responded. And if the patient respond well, then we go with the CTRT.
CTRT.
Okay. With the next the chemotherapy along with the radiotherapy, sir.
Okay, I will come back to the CTRT little later part. Anybody has got a different opinion? Number
Sir,
of cycles? Yeah.
I am giving 6 cycles only. Patient is not eligible for immunotherapy.
Okay.
And
okay.
I assess in between 3 cycle.
Okay.
And I give 6 cycle of carbohydrates, cisplatin.
Okay, Rajesh. Has Nikhil joined? Okay.
Yes, sir.
Yeah, Nikhil, what is your platinum of choice and how many cycles?
So for ES SCLC, it is carboplatin, and number of cycles are usually I do my first assessment after 4 cycles. So if they are if the response is good and there's no way of immunotherapy, so that's it, continue till 6 cycles. If there is immunotherapy also in place at 4 cycles, good response, continue with the immunotherapy only, sir.
Okay. Okay. So we will come to the immunotherapy a little later. Any other takers for irinotecan? Samir, do you use irinotecan anytime in first line?
No, sir, not routinely.
Not routinely. Reshma?
No, sir, not routinely. Irinotecan I would like to reserve for the second line.
For second line. Okay. So that's what the platinum, carboplatin and etoposide, that's the first treatment of choice with everybody. And as Samir has already shown that the data that platinum, etoposide and immunotherapy remains the standard of care for this patient in the current, in the 2021-22. It will be difficult without giving an immunotherapy. And we have already seen this data of the chemotherapy. I mean, this is the only chemotherapy in my 30 years from when I joined in Tata till now has not changed. We used to give cisplatin etoposide even that time, and we give cisplatin etoposide even now. Rest everything, majority have changed. But here I think it's the same, and a very poor dismal, very hardly double-digit median OS reaching up to 10 months, but otherwise we are seeing around 6 to 9 months. That's what the addition of immunotherapy has changed, and there are, though numerically you will not see much difference in the median OS at 12.9 months, but a lot of patients are living beyond 2 years, and now we have a data of 3 years, which was not possible earlier. So there are 2 trials which are positive, like durvalumab and atezolizumab, and we will see for all these things. So as everybody has rightly said that the first line therapy should be the best for the patient, and if there is some recurrence, then as Reshma said that she would like to see the irinotecan in the second line. Reshma, how many times you see the response in second line?
So the response in second line is not as good as first line. The PFS is even more less. It's hardly 4 to 5 months. But then that is the only options that we can give to the patient, especially those who are not affording for immunotherapy. So the response rates are not as good as the first line.
Yeah, the tolerance is also difficult in the
Yes.
that time because the patient has already gone and suffered. So these are the NCCN guidelines which suggest that adding an immunotherapy upfront to the chemotherapy is the treatment of choice at present for the patients who can afford anything. But for the others, like many of our patients, we go ahead with the chemotherapy with the only. Okay, now let me ask everyone, starting with the Samir. How do you decide about the choice of an immunotherapy, as you said in your presentation? So patient can afford anything. Now you have a patient who has just got small cell lung cancer, leave apart the brain mets right now, and metastatic disease, extensive stage disease. So you will treat with what?
So both are the fair options, but I think some points really are in favor of durvalumab here.
Okay.
So that point I already highlighted in my presentation.
Okay. So let the other answer that. Rajesh. So how do you choose atezolizumab versus durvalumab?
Yes, I agree with Dr. Samir. Since both are first line approved and both are fair option. But if patient is having brain metastasis,
okay,
then I would like to prefer durvalumab.
Durvalumab, yeah, because there is no data.
Yes.
And as somebody also said that they would like more of carboplatin, then probably atezolizumab will go. If
yes,
you are
and I am routinely using
carboplatin,
so I will
carboplatin.
I am routinely using carboplatin.
And as far as atezolizumab, the durvalumab is concerned, you can use either of the platinum, so there is no problem. Okay, so that's how you choose. Anybody, Srikant, you want to add something? If you are using immunotherapy, what will you choose?
Sir, durvalumab, because I have experience of that.
Okay.
So durvalumab.
So irrespective of brain mets, etc., you can use it. So yes. And irrespective of the platinum also you can use it, right?
Right.
Okay. So one more thing over here, the Samir, in your case, you showed that your immunotherapy was started from the 3rd cycle onwards.
Right, sir.
Okay. Now in Caspen, all the data, whatever has been there, it starts from day 1. So
right,
alone immunotherapy, I mean, only probably 1 cycle, 3rd and 4th cycle, your patient received along with chemotherapy.
Right.
Right.
Right, sir.
So
right.
do you think that there could be some difference in the what should I say, the response if you add little late?
Sir, actually difficult to comment on that, but I would say we have seen small cell lung cancer such a chemosensitive disease. With 1-2 cycles of chemotherapy, we get the maximum response. So whatever the downstaging happens, whatever the tumor killing happens, that is in first 1 or 2 cycles only. So I think technically should not make any difference, but difficult to comment on that.
Reshma, when do you add immunotherapy? Day 1?
Yes, sir. As per the data, we should be adding it from the first cycle itself.
Yes.
So yes, sir, I want to add it from the first cycle only.
Okay.
Sir, sometimes patients come very sick.
Yeah.
That time even giving doublet is difficult. So in those patients, what we give is we give a single agent carboplatin, and from next cycle we can add doublet or even triplet. We can add immunotherapy because tolerating
immunotherapy
carbotopo in a very sick patient with PS3 is difficult.
Yeah.
So see, the rationale I have mentioned here in my presentation. So when the tumor cells are killed by the chemotherapy, the neoantigens are expressed, and they get exposed to the T cell, but these cells are inhibited. So even if you add from 3rd cycle, the neoantigens are there, and the immunotherapy is going to work even from the 3rd cycle also. So technically, rational wise or conceptual wise, if you see, it should not make any difference, but we don't have such data to tell that it will not make any difference.
So idea of
whenever possible from cycle 1 only we should add.
Yes, idea of raising this question was that try to use from the day 1. If you,
right.
Let me take a corollary in breast cancer. Okay, there is an HER2 positive breast cancer. Now you want to give trastuzumab, right? Everybody gives trastuzumab. But if you add trastuzumab after completion of chemotherapy, it doesn't work.
Right.
So there we give along with the either paclitaxel or docetaxel.
Right.
So there is some others there. I mean, there logically there also HER2 positive cells it should work.
Right.
So let's try to stick to the protocol. And I know the practical difficulties are so many. Even if we tell the patient on day one, they may not be ready financially. Agreed. But we will let us make this habit of using the data to the fullest, and the use accordingly.
Right.
Okay. So this is the 3-year data of the Caspian, and where it had shown that almost 17.6% patients are alive when they receive the durvalumab in addition to chemotherapy as compared to other. And Empower data is not yet mature for 3 years. It is only they have published the 2 years. And if you see, it's looking like a class effect. Exactly at 1 year, both are 50%, at 2 years at 22%. But 3-year OS data has not been reported in the atezolizumab. So what do you think, Srikant? Do you think it will be same?
Can you repeat, sir, the question?
No, the question is at the end of the 3 years, if you look at these two drugs, durvalumab and atezolizumab, at the 1 year, 52% approximately. At 2nd year, OS is around 22%. At 3 years, do you think both will be same or something different? Whatever.
My apologies, sir. You are just left with 5 minutes to conclude your panel discussion.
Okay.
Thank you.
I hope, sir, the both, because the mechanism of action is almost the same. So I hope the second one you also will have the same data at 3 years.
Okay. So this patient received durvalumab, and after that, the patient received every 4 weekly the maintenance therapy and serial scans after that. Okay. So now the question of radiation. Samir, you showed that patient received 18 fractions of radiation. So whole brain radiation being given 18 fractions.
So I think there was a boost given to the site of largest metastasis site.
Anyway, none of us are radiation oncologists over here, but if
So
somebody wants to comment.
fraction is the standard, but I think he was given a boost to the largest tumor.
Nikhil, do you want to come over here? How
Yes,
many
sir.
your patients normally take the brain radiation, whole brain radiation?
Sir, I do recommend, but I just leave it on to the radiation oncologist to decide on, obviously, number of fractions is his decision. Whether PCI yes or no, I just leave it on to them, because sir, even if you don't give PCI, the relapse is really fast, is what I've seen over the period of time.
Okay. So let me just come to the data that's saying that there is a Japanese data. Older data suggested that PCI should be given to all patients. But this is the Japanese data from the Japanese Takahashi, which showed that there is no benefit of PCI in the patient who had in the patients of extensive stage lung cancer. So you can use it or you may not use it. And these are all data when it was old. In the immunotherapy era, we don't know whether PCI stands any chance this time or no. But current practice, yours and mine, is that yes, we go ahead and give the PCI. Srikant, you said radiation, CT, RT. What CT and RT you were giving? Srikant?
Sir, yes, sir. In extensive stage, because we are talking about the extensive stage. So what we are practicing here in our institute, that after 4 cycle, if the patient response is well, then we go for radiotherapy.
To what area?
To the PCI as well as the radiation to the chest also.
To chest, okay.
Yes,
okay.
Yes, the chest also.
Okay, this is the question and this is the data. So there is benefit of radiation, thoracic RT, which is given to the patient, but it is only for the patients who have some residual disease after systemic therapy, but they should be a limited, less than 2 metastases. Then only it helps, otherwise it doesn't help. So do you follow the similar kind of guidelines, or how do you do that?
Yes, sir. Usually those patients who have because the radiotherapy, apart from PCI, we used to give radiotherapy to the chest wall. So if there is extensive disease, even after the chemotherapy, definitely would not prefer to go for. Then we put patient on after the completion of chemotherapy, we put patient on the follow-up if the patient is asymptomatic and patient responding.
So
And
NCCN
if patient is not taking this immunotherapy.
NCCN has also changed now PCI or surveillance. Now they have put both. If either you can go ahead in extensive stage or not, you can decide about that. So this is the treatment algorithm what we discussed. First line chemotherapy and immunotherapy for all patients. People also discussed about the patients who could not tolerate chemotherapy upfront doublet. So you can use either single, that is what has been said. But if you look over here, they have suggested that the best supportive care is people, I mean, as far as the ISMO guidelines are concerned, the combination of chemotherapy is the only option which has to be given to the patient. And once they improve, then you can go ahead and give the therapy. But practice-wise in our country may be a little different. Okay, so anybody else has got any comment, because we are almost on the verge of finishing of our time. Somebody wants to add something, right from Nikhil, Samir, Rajesh, Reshma?
Sir, I want to ask a question that if the patient is put on thoracic RT or PCI and is on immunotherapy maintenance, is it safe, or should we be worried about any side effects?
Yeah, I mean, we know that from the non-small cell lung cancer study, so there are pneumonitis chances are high.
Yes.
When the patient, so you have to take care of that. That's the only thing. Pneumonitis will be high.
Okay, sir.
So if there are no more, then this was probably we should stop it here and hand over back to the organizers. And thank you very much for having a wonderful discussion.
Thank you, sir,
Thank
for the
you.
wonderful panel discussion. Next, I would like to invite Dr. Bhushan Jade, who is consultant radiation oncologist, Ruby Hall Clinic, Pune, and he's going to talk on a role of RT in the management of small cell lung cancer. Over to you, sir.
Hi, good evening all. Can I, my slides audible and I'm visible?
Yeah, you are audible and
clear?
your slides are visible. Yes, sir.
Okay, I'm just moving my slides. This moment is appropriate.
Right, sir.
Okay.
Correct.
So at the outset, I would like to thank all the organizers for inviting me over here. And I start with my topic of discussion, radiation therapy in the management. As we all know, small cell lung cancer is the second most common thoracic malignancy. It's aggressive malignancy. 1/3 of all these diseases are localized, or traditionally they are called limited stage disease, HCC 1 and 1, 2. And majority they presented a metastatic, or what we call this disease. And standard treatment for all these limited stage disease has been chemotherapy with early administration of radiation therapy and prophylactic cranial radiation. And extensive stage disease treatment is mainly chemotherapy with or without. So what has happened in recent times, like multiple high impact phase 3 trials have challenged the traditional approach of radiation practices in both limited stage and extensive stage disease. A few to mention: CREST reported overall survival benefit with addition of thoracic radiation in extensive stage disease, which otherwise we don't give radiation in extensive stage disease. But yes, this trial has addressed that issue. We'll discuss it. Convert trial has reported survival and toxicity differences in 2 radiation fractionation protocols with modern radiation therapy techniques in limited stage disease. Japanese PCI trial questioned PCI with modern imaging surveillance modalities in extensive stage disease. And addition of atezolizumab or other immunotherapy agent with radiation has changed few things. So let us start this discussion with everything put together. We have radiation therapy for small cell lung cancer and ASTRO consensus guidelines, and we are going to base our flow of our discussion on these practice guidelines. So what are the key questions we are going to discuss in this 5-10 minutes of my presentation? Radiation therapy in limited stage. This, any role of SBRT in stage 1, stage 2 disease with no nodes? What are the different approaches and what are the controversies related to prophylactic cranial radiation? What is the role of consolidation radiation in extensive stage disease, immunotherapy, and few future directions? So radiation therapy has been part of curative intent treatment in limited stage disease with survival benefit both clear in recent and historical data. Concurrent chemo radiation is good. We have randomized data for that. And when we cannot give concurrent chemo, definitive radiation remains standard of care for not so fit patients. And timing of radiation. Earlier thoracic RT is superior to delayed RT. We know with the data I'll present later. Radiation therapy should start with 1 to 2 cycles, first or second cycle. But however, there is a word of caution. If there is some logistic reason in starting radiation, like waiting period or radiation therapy planning time, or radiation therapy center is not very close to patient's place, then in that case, we should not wait for radiation therapy. We should start ASAP with chemotherapy and add radiation as soon as possible. And in select patients with bulky disease, radiation therapy with third cycle may allow tumor shrinkage and lower radiation therapy related toxicities. And this is a systematic review and meta-analysis of randomized trials addressing timing of radiation therapy in limited stage disease. We have a significant 2 and 5 year survival improvement when radiation therapy started within 30 days of platinum-based chemo. So radiation should be started ASAP, if not on day 1. And this was even more pronounced when the overall treatment time of chest radiation was less than 30 days. So this meta-analysis and systematic review addresses this question that radiation should be started ASAP in limited stage disease. Optimal dose and fractionation. We have 2 randomized trials and few smaller studies. Hyperfractionation means 45 gray in 30 fractions twice daily, delivered 6 hours apart over 3 weeks. It's kind of a standard of care. But at the same time, for logistic reason, daily radiation therapy of 60 degrees or 70 degrees acceptable alternative. And traditionally, when CT or PET scan was not there, the radiation therapy portals were big. But now with modern practices, involved field radiation, like what we see, we treat, kind of approach is always better with to minimize toxicity of radiation. Now, this is a convert trial which addressed in a randomized fashion the twice daily regime of radiation with once daily regime of radiation, keeping all other chemotherapy parameters similar. And what we see, of course, there is a slight benefit of twice daily regime of radiation as compared to once daily, but there is no statistical difference, statistical difference. So both regimes are comfortable. Preference is for hyperfractionation, but in view of logistic problems, even once a daily fractionation is also good. Any role of stereotactic body radiation in stage 1, stage 2 small cell lung cancer? We are extensively using SBRT in non-small cell lung cancer in stage 1 or stage 2 disease. But what is evidence in small cell lung cancer? We know what is SBRT. High doses of ablative radiation to small targets in 1 to 5 fractions with highly conformal techniques. To date, data with this technique for this stage limited. There are no completed randomized control trials for SBRT in small cell lung cancer. But yes, there is a situation, non-operative candidates owing to medical conditions, functional status, poor baseline lung capacity, or preference to avoid surgery. Yes, they are kind of a candidates which may be suitable for SBRT. And of course, a word of caution, SBRT is less suitable for intracentral tumors because of concerns of toxicity. Now, very controversial topic and very a topic which has got many kind of a confounding factors or variables is prophylactic cranial irradiation in small cell lung cancer. So, what are the indications, appropriate dose fractionation and timing of PCI? So, standard platinum etoposide chemotherapy, which is extensively used for small cell lung cancer traditionally, of course, has limited penetrance in central nervous system because of blood-brain barrier. And when up to 60 to 70% of patients ultimately develop brain metastasis. Meta-analysis of clinical trials, mostly patients with limited stage disease, has demonstrated overall survival benefit of 5.5% at 3 years. Now, with this newer MRI imaging techniques, so is there any role of MRI restaging and PCI in limited stage disease? So we have a pooled analysis of 2 randomized studies assessing over 500 patients and 5-year cumulative rate of brain metastasis as first site of relapse was 37% in control group versus 20% in PCI group. So with this trial, we have significant less brain metastasis in PCI group. And studies in limited stage disease after negative restaging of MRI following chemoradiation show brain mets development in 35 to almost 50, 45.
My apologies, sir. You are just left with 1 minute to conclude your presentation.
Sure. Managed without PCI.
1 minute left, please. Yeah.
Patient
Thank you.
managed without PCI has got high recurrence in brain. So PCI remains standard of care in most patients with limited stage disease who respond to upfront chemoradiation. Now, is there a role of PCI in extensive stage disease? Yes, we have multiple meta-analysis and pooled analysis, and majority of data suggesting reduction of brain metastasis, but overall survival was not improved. Therefore, in extensive stage disease, patient who improve on chemotherapy can have a MRI restaging or MRI surveillance instead of PCI. Can we avoid PCI at all? So there are subgroups in which PCI can be avoided. Stage 1 disease, low incidence of brain mets can be avoided. More than 70 years of age, incomplete response to chemoradiation. Given this uncertain benefit in this subgroup, there is a situation for MRI surveillance and PCI can be avoided, but it has to be discussed with the patient. In the role of thoracic radiation in extensive stage disease, yes, we have 3 randomized trials and 1 meta-analysis. Patients who had complete response outside thorax and partial response inside thorax, a CREST randomized trial has and thoracic progression reduced by 50%. So there is a role of radiation in extensive stage also. With immunotherapy, addition of this immunotherapeutic agent, but all these trials has not got radiation therapy as a standard treatment, but some patients did receive radiation as a palliation, and the task group has suggested because of low side effects of palliative radiation, there is a still role of radiation to thorax in incomplete response after completion of systemic therapy. I'll end my topic with this future of radiation in small cell cancer slide. So ongoing KGB trial, once versus twice daily RT with concurrent chemotherapy in limited stage disease, and there is one ongoing trial, randomized trial assessing role of immunotherapy with concurrent chemoradiation in small limited stage small cell lung cancer. Thank you very much.
Thank you, Doctor, for the lucid presentation. And next, I would like to invite Dr. Nikhil Pandey, who is consultant medical oncologist, SCG, NCHRI Cancer Center, Nagpur, and he is going to deliver his talk on newer updates in LS-SCLC with IUs. Over to you, sir.
Ma'am, can you share my slides?
Arham, can we do that? Also, B, can we do? Yeah. Here's your slide, sir.
So I'll just, good evening, everybody. I'll just limit myself for the 10 minutes that I'm there, and I'll just talk about the newer updates in LS-SCLC with IOs. Next slide. So I'll just skip some of this initial data. We have already gone through it. Next slide. Next slide. So we all know the 5-year survivals are dismal and we need to improve it. Next slide. So next slide. So we all know the modified VA lung group staging for SCLC, wherein we divide it into a limited stage or an extensive stage. By definition, the limited stage is disease confined to one hemithorax with hilar and mediastinal adenopathy that can be encompassed in a tolerable radiotherapy portal. The keyword is tolerable, and it excludes malignant effusions and excludes contralateral hilar and supraclav nodes. Next slide. So primarily, only 1/3 of the patient is what we are talking about in the limited stage. Next slide. Next slide. We all know smoking is a leading factor, but only 2.5% of the SCLC cases in the US are diagnosed in never smokers, but an estimated 10 to 15% of NSCLC cases in US occurs in never smokers. So if you have an LCLC diagnosis with a never smoker, I think we should relook at the diagnosis. Next slide. So how do we do it? In clinical stage, T1, T2, N0, pathological and mediastinal staging negative. If you have got a positive mediastinal staging, positive or medically inoperable or decision made not to pursue surgical resection, I think you should go to the next year. But in this initial treatment, you would consider a lobectomy, which is preferred with mediastinal lymph node dissection or sampling. And the adjuvant therapy, N0 is systemic therapy, N1 is systemic therapy with without mediastinal RT, and N2 is obviously systemic therapy with mediastinal RT. If you have got a limited stage in excess of T1, T2, N0 with a good PS, systemic therapy with concurrent RT should be your preference. But poor PS due to SCLC, systemic therapy with or without RT, or individualized treatment including supportive care. Next slide. So, as we all know, most patients relapse after the initial treatment only, wherein even in the response rate in limited disease is good, but most of them would relapse post first-line treatment. Next slide. So what is the scope of problem as of 2017? Effective therapy is critically needed. The LS SCLC, the median OS of 15 to 20 months is something which needs gross improvement, and 6-month increase in survival versus control arm on therapy. Next slide. So this is something which we have already talked about. What has been the schema of events which has happened over the years. Next slide. For limited stage SCLC, the first line therapy, standard of choice is concurrent chemotherapy with RT. Standard chemotherapy is combination etoposide and cisplatin 4 cycles. RT timing and dosing, as sir had already mentioned, about once daily RT to 60 to 70 gray to or twice daily RT to 45 gray is the usual thing which we do. T1, T2, N0, M0 surgery with adjuvant chemotherapy with or without RT. Next slide. So there's a randomized phase 3 study of EP versus CEV into 5 cycles in SCLC, where RT for 3 weeks after CT cycle 3 and PCI for patients with CR, and OS favored EP over CEV regimen, and concurrent CTRT did better as compared to sequential CTRT with a median OS of 27.2 versus 19.7. Next slide. As compared to the radiation, sir has already talked about concurrent and sequential, and whether to give twice daily versus single daily. But there was obviously more toxicity with concurrent approach, but a survival trend always favored concurrent chemoradiation. Next slide. So this trial also, sir just mentioned about the concurrent BID versus once daily dosing of in limited stage SCLC, where there was no significant difference in median OS, but 25 months OS for OD versus 30 months OS for BD. The hazard ratio was 1.18, and there was an almost similar toxicity between the two groups. Next slide. So, small cell lung cancer and NSCLC, we obviously subtype, but in SCLC, do we really subtype them? Next slide. So, what is the genetic alteration in SCLC? No clear targetable oncogenic driver, with nearly all tumors have loss or inactivation of TP53 and RB1, and the MYC family that is the member amplification is very common. MYC L1 over NMIC versus over CMIC. Additional alterations include FGFR1, SOX2 amplification, recurrent point mutations in chromatin modifiers, and others. What is the biological rationale for immune checkpoint inhibition as cancer therapy? This has already been told, but anti-CTLA4, ipilimumab or tremelimumab, they have inhibitors with signal blocked by antibody binding, and tumor microenvironment, anti-PD-L1 and anti-PD-L1 are something which can be effective. So next slide. So rationale to combine ICI with chemotherapy in SCLC is always there, where chemotherapy-induced tumor cells may induce tumor antigen release and exposure to immune system. And PD-L1 over, can you go back to the previous one? And the PD-L1 overexpression leads to immune cell evasion and T cell inhibition. As the rationale for PD-1, PD-L1 inhibition. PD-L1 inhibition restores tumor-specific T-cell immunity, and reversal of immune suppression leads to deeper, more durable systemic anti-tumor response. Next slide. So PD-L1 expression was the previous one. PD-L1 expression was observed in 72% of SCLC specimens and significantly correlate with limited stage disease. And OS, if you consider by PD-L1 expression, PD-L1 positive have a higher OS as compared to PD-L1 negative. Next slide. And we all know that SCLC has a higher tumor mutational burden, where it stands way above the other tumors and in close association with lung and melanomas. Next slide. So is there any ongoing tumor trials for immunotherapy in SCLC? Yes, there are. CTRT followed by durvalumab or CTRT followed by nivolumab and ipilimumab. These are the two clinical trials which are important after first-line consolidation in limited stage. IO plus IO combination is also something which is being studied, where durvalumab is being studied with tremelimumab and pembrolizumab with two other agents. IO plus chemotherapy.
My apologies, sir. You are left with just 1 minute to conclude your presentation. Thank you.
Yes, ma'am. IO with chemotherapy is something which is, again, so as sir said, does it all, like the discussion was in the previous one, when should durvalumab be started in extensive stage? So similarly, does it make sense to combine IO in the initial part only with chemotherapy? That is being studied. Plus, there is a last study of durvalumab with olaparib, that is the Mediola study, which is in second line extensive stage, but this is something which, if successful, will bring about a change in our way of practice. Next slide. Adriatic is consolidation durvalumab versus durvalumab, tremelimumab versus placebo in SCLC after CTRT. It is durvalumab continuation and treat until PD or intolerable toxicity or maximum of 24 months, that is 2 years. And the primary endpoint of this study is PFS and OS. Next slide. As is the NRG LU005 study, where concurrent chemo-RT versus concurrent chemo-RT plus atezolizumab for LSLCSC. This is almost on the similar lines, but here is starting after cycle 2 of chemotherapy, and first chemotherapy cycle must be given prior to study entry. The primary endpoint is again PFS and OS. Next slide. There is also the Stimuli study, which is a phase 2 trial of consolidation nivolumab and ipilimumab in limited stage SCLC after chemoradiation. This is 4 cycles of chemotherapy plus thoracic RT, followed by nivolumab and ipilimumab versus placebo. Next slide. And this is the Kaplan-Meier plot for PFS by the treatment. So the events in itself were a little limited, but the median PFS did favor the observation arm of 14.5 months versus the median PFS of 10.7 months in nivolumab plus ipilimumab. Next slide. So exploration and treatment effect within levels of clinical pathological variables of interest. If you look at the subgroup analysis, it definitely did not favor the nivo plus ipi arm. Next slide. So if you look at the key studies, there's the checkmate of 032, which is in nivolumab plus ipilimumab versus checkmate 331 of nivolumab monotherapy. This is after in second line, but the first line maintenance is what we are looking at. Next slide. Nivolumab plus ipilimumab in advanced SCLC is something which we already know about. Next slide. That is, the study demonstrated that nivolumab plus ipilimumab is better after progression on 2 or more lines of therapy. Next. And response by PD-L1, yes, it did make a difference. That response did make a difference. But these are the studies which is in the second line where Nivo plus EP has favored, but not in the first line where Nivo and EP was given as compare in maintenance arm. Next slide. This resulted in nivolumab approval as a single agent for patients with advanced SCLC and PD after therapy. Next slide. In relapsed SCLC, yes, we know nivolumab did better as compared to next slide, topotecan or ambrisentan. But after a certain time, the PFS at 12 months was almost equal. Next slide. Next slide. So if you look at the immunotherapy response on to prior treatment with platinum therapy, the median OS of nivolumab of 7 months versus 5.7 on chemotherapy, and platinum refractory and platinum sensitive of 7.6 versus 11.1 months clearly show that probably it is the nivolumab platinum refractory patients which we need to target with nivolumab. Next slide. Next slide. So in summarize, with aggressive or concurrent chemoradiation, high likelihood of response, even CR, but possibility of long-term disease-free survival is less. However, as we know, most patients will respond. Stimuli trial did not meet its primary endpoint, but treatment for advanced SCLC are an unmet need, as we have already just discussed. But something which we are really looking forward to, does durvalumab maintenance or IO plus IO combination of pembrolizumab with either one of the two investigational agents. These data is something which we are really looking forward to. Even in, if we cannot directly correlate, but even in cervix where durvalumab maintenance is something which is really going to be helpful. Next slide. I end my presentation and sorry for the increase short.
Thank you, sir. Thank you, Nikhil Pandey, sir. Next, I would like to welcome Dr. Akash Tiwari to chair the session, and he is consultant medical oncologist, Shelby Hospital, Indore, to welcome our today's international speaker, Dr. Mark Vincent. Over to you, Doctor.
Good evening, everyone. So our esteemed guest speaker today, Professor Mark David Vincent, is currently Professor, Department of Medical Oncology, Division of Medonc in the Schulich School of Medicine and Dentistry in the University of Western Ontario. He has received awards for Excellence in Academic Award and Excellence in Teaching Award from his institute. He has published over 120 peer-reviewed articles in various international journals, and he's also author of several chapters and books. It is a privilege to have you, sir. Dr. Mark Vincent will share his views on management of stage 3 NSCLC evidence and experience so far. So the stage is all yours, sir.
Thank you. Can you hear me?
Yes, you are audible.
Okay. Can you see my slides?
Yes, clearly.
Okay, thank you. So good evening, everybody. It's morning where I am, but I think it's evening where you are. Unfortunately, we're still virtual, but I'm going to be talking on management of non-small cell stage 3, some evidence and experience so far. These are my disclosures. And we're going to just go over a quick review of the definition and incidence of stage 3, which this audience is familiar with. The immune checkpoint inhibitor concept, 5-year update of the Pacific, the role of the MDT, the use of durvalumab in sequential versus concurrent, and the use of durv in cases with the drug ball driver mutation, and a little bit about the management of pneumonitis. So stage 3 is a complicated heterogeneous group of non-small cell lung cancers. There are at least 39 combinations of T and N in the 8th edition, which has been updated. But we know it's not the early ones that are resectable, stage 1, stage 2. It's not the advanced metastatic distant disease. It's kind of everything in between. I think that's a quick way to summarize it. Mostly it's patients with mediastinal lymph nodes, either N2 or N3. We know this is about 25% of non-small cell lung cancer. We know that it's curable in a proportion of people, a minority, maybe around 15-20%. We know that the addition of chemotherapy improves survival over radiation. There's a meta-analysis that's been done showing a really modest benefit. And if you do concurrent chemoradiation as opposed to sequential, that's chemo first and then radiation, there's a bit of a benefit to the combined concurrent chemoradiation, but it's not really a huge effect. And in fact, sequential chemoradiation has been recommended in ESMO guidelines as an option in the right kind of patient. We know that patients who may be older, more frail, have bigger tumors, they may need to be treated by a sequential approach, whereas younger people with smaller tumors that are fitter should be treated by concurrent chemoradiation. I'll just say the original Dillman study in 1990, which showed the benefit of chemo with cisplatin vinblastine, followed by radiation, obviously was a sequential study compared to radiation alone. So there's reasonable evidence that sequential chemoradiation works and is okay in the right kind of patient. There's certainly more toxicity when you do it concurrently with esophagitis. There's definitely less significant, grade 3, grade 4 esophagitis, only 4% when you do it sequentially. I'm not advocating sequential. I'm just saying it's okay in the right kind of patient. We do know that in this meta-analysis from 2010, there's a bit of a survival benefit from concurrent versus sequential, about 10% going up to about 15%. But either way you slice it, this isn't great. We have tried many, many things to try to improve this over the last 30 years since the Dillman. We have tried consolidation platinum-based chemotherapy, as in this slide here. We tried consolidation docetaxel, which didn't work. We've tried higher doses of radiation, which didn't work. We've tried pemetrexed based in the non-squames, and certainly it seems to be equivalent and less toxic, but it's not more effective. We've tried various vaccines and tried twice-daily radiation, and none of these have really made any significant difference. And so what we have been doing up to now is a chemoradiation, either sequential or concurrent, and then patients have been on surveillance, and you just wait for the other shoe to drop. And we know that most of these people will relapse and will die. The surgeons, of course, have had a good role here in terms of the research. This is a famous study of intergroup 0139, and they randomized people. Everybody got 45 gray with 2 cycles of platinum etoposide, and then they were reassessed, and if no disease progression, they were either went on to surgery or to radiation to completion of 61 gray. There was no overall benefit in the intent to treat population. But if you could get away with a lobectomy, and this is the yellow line to people who actually had a lobectomy, it appeared to be better who had chemoradiation who would have gotten away with a lobectomy. This is hypothetical data in blue, it's real data in yellow, but the opposite was the case for people with pneumonectomy. If you had a pneumonectomy, you didn't do that well with radical radiation or any radiation at all. Whereas people on the blue who just got the chemotherapy and radiation without the surgery, but who would have had a pneumonectomy, actually did better. So there's a little bit of a kind of a dichotomy there based on the extent of disease. And the message here is don't do surgery if you're going to have a pneumonectomy. Whether you should do it with a lobectomy is what we're going to be talking about a little bit. And what we see is that surgery in this intergroup study did protect from local failure, from 22% down to 10%, but it did not protect from systemic failure. And systemic failure is by far the commonest form of recurrence. What about single station N2? Well, it's certainly better than multiple N2, even single station in the upper mediastinum, but you're still only hitting about 55% 5-year survival. That's not great. The South Koreans did a trimodality study in very selected patients, nearly 600. 76% of them were single station N2, kind of best of the best for surgery. And unfortunately, by 5 years, the progression-free survival was only 29%. I mean, it's more than, almost 3/4, 70% of these people had failed, and most of the recurrences, 80% plus, were systemic, brain, liver, bone, So unfortunately, although surgery is technically good, they're expert, and we love our surgeons, The problem with this disease, stage 3 non-small cell lung cancer, is that most of the time there are already micrometastases in a disseminated way. And surgery is like closing the door after the horse has bolted. So we have to think different, not to say there isn't a role for surgery. There probably is in some selected people, but we have to think differently. And the different thinking is around the immune system. There's the cancer immunity cycle. Cancers shed antigens. They're processed by dendritic cells. There's checkpoint in the lymph node, CTLA4. There's checkpoint back at the tumor, PD-1. So the immune system doesn't work if these checkpoints are inhibitory. And radiation will help in many ways. It allows trafficking of the immune cells back into the tumor, lots of release of antigen, lots of cytokines, some of which are helpful, but upregulation of PD-L1 is an off switch. It's an off switch on the immune system. Chemotherapy can help, and what it helps is in many different ways. It allows the dendritic cells to be more active and more mature and help to process the antigen and present it to the T cells. So the idea here is that chemotherapy and radiation is going to be on balance helpful, but there is still this problem of upregulation of PD-L1 following radiotherapy, and that needs to be blocked because it's an off switch. And so there's durvalumab, which is an anti-PD-L1 antibody, which can block PD-L1 both on the tumor cell and on the antigen presenting cells. So now the T cell is activated and not inactivated. And so the Pacific study built in these concepts with people who had chemo radiation concurrent, platinum-based, who'd done okay. There was no evidence of disease progression. They were randomized 2-to-1 to durvalumab every 2 weeks compared to placebo, with PFS and OS as the co-primary endpoints. Lots of different platinum regimens, but most of the patients got etoposide with the platinum, but include either cis or carbo. The 5-year update's been published. These curves separate early. I think you know that by now, but they stay separate out to 5 years and probably beyond. This is the 5-year overall survival, about an extra 10%. If you look at the PFS, which of course is people who are still alive at 5 years, they haven't died of heart attacks and strokes and so on, we see that there's about a 14% increase in people who are probably cured. So 1 in 6 people now additionally can be cured of this disease. So it's no longer just a question of nihilistically waiting for the relapse to occur. We can do this proactively, give this 1-year durvalumab post-chemo radiation, and an extra 1 in 6 people actually be cured. And there is massive protection from systemic recurrence. You can see here very substantial protection from metastatic disease. And we know that even non-smokers can benefit, actually, somewhat surprisingly. And we believe in the 5-year update that there's probably some benefit in some people with EGFR mutations, although the confidence intervals are wide because there weren't that many people. If we look here at the PD-L1 negative patients, this was an issue in Europe. People were concerned about, it was maybe the survival benefit wasn't there in the PD-L1 negative patients. The 5-year update is that, it's not powered for PD-L1 negative patients. There's wide confidence intervals, really 95% confidence intervals, but it doesn't appear to be that harmful. And there's a PFS benefit for PD-L1 less than 1%. PD-L1 more than 1, more than 25, less than 25, all benefit. And so we know that there's a lot of problems around measuring PD-L1, about heterogeneity and it going up with radiation and so on and so forth. In North America, in Canada, which is a country that's very careful with money, we are okay to give durvalumab in people who are PD-L1 negative or positive, whatever the PD-L1 status is. We do see a bit more benefit with cisplatin than carbo. We see more benefit with people who are put on it early, within 14 days, compared to 14 to 42. So we know that, people get beaten up, sometimes chemoradiation, sometimes they have to wait, you can't help it. But it is better to get people on earlier if you can. You're going to need to book the CT scan, prepare the patient, and have everything streamlined ahead of the time. And then it can work smoothly and you can get the right kind of patient on early. The tumors continue to shrink on the durvalumab compared to placebo, so the response rate is higher. The toxicity is relatively low. There's very little grade 3 or 4 toxicity. I'm not saying it can't happen, but there's very little, and some of it is, radiation, a little bit more perhaps radiation related, or perhaps some durvalumab pneumonitis, but it tends to be grade 1, grade 2. There's a little bit of rash, there's a little bit of hypothyroidism, and there's the incidence of pneumonitis compared to control, 7% versus 11%, and very little severe pneumonitis. There are a few people, perhaps 1 out of 20, who have to discontinue on the development in excess of the placebo. But for this relatively well-tolerated drug to do this amount of good is a very good deal in oncology. We don't see it that often. And this is just to emphasize the very substantial protection from systemic recurrence, half the incidence of brain mets, 2/3 the incidence of liver mets, half the incidence of bone and adrenal metastases, and so on. So there is certainly protection from systemic disease, but there's also protection from local failure to some extent. So this is compared the intergroup study showing, surgery helps local control, no doubt, but there's no help really with systemic recurrence, which is the big problem. The Pacific study really shows substantial protection of both local and distant disease. And you can't do that in any other way that we know about right now. And so there's big increase in the survival, 30 months up to 48 months, big increase in progression-free survival by 1 year, and a better response rate. There's no impact on quality of life in a negative way. So it looks like consolidation maintenance development increases the cure rate. And we know that now because we have 5-year survival. It is unlikely that they're going to be very, very late. Who knows? Anything's possible, but it looks like we're curing more people. And I think you're obligated to inform your patients of that. There's a huge program now with durvalumab in resectable and unresectable and stage 4 disease. I'm sure the company will be very happy to share that with you. I'm just going to talk a little bit about some real world evidence conducted in Europe and Australia that looked at 1,400 patients treated with chemoradiation, and if they had not progressed, they were given durvalumab. 15% of these people had to have sequential rather than concurrent because they weren't that fit. Who gets sequential? Well, it's older patients with bigger tumors. That's not a surprise. We know that happens all over. We know that many of these patients had a considerable burden of comorbidity with, blood pressure, COPD, heart, and so on. The PFS in this group was very good. It seemed to be longer than in the Pacific study. That was a soft endpoint. We're not saying it's genuinely longer, but of course, in a non-formal trial, it's more difficult to assess PFS accurately. But survival you can assess. And so we see here sequential versus concurrent, there's very little difference. So what this means is that sequential is okay. It's okay to do sequential. It's a bit better to do concurrent, but sequential is okay in the right kind of patient. And you can see the stage 3, 3A versus 3BC, PD-L1 negatives don't do that bad. Obviously it's better if they're PD-L1 positives, but it's okay to do it in PD-L1 negative patients as well. Of course, non-squams do better than squams, and we've known that for a long time. There's a relatively manageable incidence of pneumonitis in this real-world evidence study. So here's a case report. It's an elderly gentleman who had a stroke, and while he was being worked up for the stroke, they found a little nodule in his lung with some N2 nodes. There's the PET scan. He has a biopsy, which is poorly differentiated non-small cell lung cancer, strongly PD-L1 positive. He has no detectable mutation. He's given chemoradiation. He tolerates it okay. And then he's placed on a year of durvalumab as his nerve and disease progression. He swings through the durvalumab, no problem, despite the fact he's 75 years old. After 3 years, he gets a brain metastasis, solitary brain met. It's a late recurrence. He gets it resected for cure. It has a little bit of a different characteristic. The PD-L1 now is 1 to 49. He has a P53 mutation. Is it the same cancer? Well, we staged him head to foot. There's nothing else. He seems to be clear from the neck down. So he was treated with surgery, brain resection, brain met resection, and then SBRT. So he's now a curative intent patient again. He was over 75. He's had a recurrence. Did we do the right thing? People over 70, they have the same degree of benefit. Absolutely, we should have given it to him. So we have confidence we did the right thing. He's now curative intent again. He had a very long disease-free interval and very good quality of life. The critical role of the MDT, very briefly, we know that with the COVID, the number of patients presented and discussed at the MDT has declined. We know that you can use telemedicine now to get around some of these problems. We know that the time to treatment with therapy, either radiation or systemic recurrence, this is US data from Philadelphia, there's no delay if you do this properly. There's a bit of a delay, however, with surgery. Surgical patients may not be that. We may need to see them in person. Here's the core of the MDT, the 3 specialties, radiation, med-onc, surgery, but the pulmonologist, the pathologist, the radiologist, the nurse, the research, this is all critical for the core. We know that This cannot be done necessarily in every peripheral center. So you can have national or regional MDTs and you can patch them in with good technology today. And you can make this very sophisticated, but I think the key thing is you need your core local MDT, if at all possible. We know that there's issues around workup, there's issues around management. All of these things can be profitably discussed at the MDT. And we know there is good data now that patients who get at least an opinion, not necessarily the treatment, but an opinion at an academic center do better because they're more likely to get guideline treatment, they're more likely to get new drugs, and then the ability to communicate between the peripheral center and the regional academic center is critical to bring equity of care across large countries like Canada and like India. And we know that we can do it now with technology, and the COVID situation has pushed us in that direction. This is data from SEER, the United States, showing that nearly 50,000 patients, only a quarter of them got guideline mandated treatment. And you know what? They do better. Here's the dashed line. They do better. The hazard ratio for people who don't get guideline mandated treatment is 1.42. So people do better with academic, at least an opinion in an academic center. So stage 3 with driver mutations, and I'll just skip here to show that we know that, KRAS, BRAF, and MET14 skip, we know there's good data. They do quite well actually on being exposure to immune therapies. I mean, there may or may not be driver drugs you can use, but if you use immune drugs, they do quite well. HER2 mutations and EGFR mutations, there is some evidence that some of those patients can benefit, not all of them, but some of them can. So it is not unreasonable to consider immunotherapy in some patients with EGFR mutated lung cancer, particularly. We know there's data from the IMPAL 150 study showing, for example, better response rate, better PFS in these patients, and a better overall survival with the addition of atezolizumab, which is an anti-PD-L1 antibody. So there is data showing that some people can benefit with, including, by the way, in the Pacific study, which I've mentioned, the overall survival and the PFS in the 5-year update seems now to be favoring, although the confidence intervals are wide because not that many patients. There is the LAURA study ongoing, stage 3 chemoradiation, then randomized to osimertinib or placebo. We don't have that data yet. In the long run, I don't know, will osimertinib be better? Will development be better to treat these people? It's a bit of an open question. In the meantime, we're comfortable giving it to EGFR positive patients in Canada. Here's a quick case report of a 52-year-old woman from the Philippines living in Canada, has a lump in her neck, never smoker. There is the disease in her neck. There's the big mass in the right hilum. There's the N2 node. Here's the biopsy showing a gland-like formation of positive TTF1. The rest of her staging was negative. She's PD-L1 intermediate, 1 to 49. She has a sensitizing EGFR mutation. She has, this is her baseline chest X-ray. This is the baseline PET scan. She has cisplatin etoposide and 60 gray, very, very standard. We see that there's no evidence of disease progression. We see that he has pre, he has post. It's kind of responded, not wonderful after chemoradiation, but it's not getting worse. So we felt that this was okay to give her durvalumab. She had 1 or 2 cycles. She started to get a bit of dyspnea. We did a CT scan. There's pneumonitis but it's in the radiation field. This is probably radiation pneumonitis more than durvalumab. But we held the durvalumab. We treated her with prednisone. And after a while, by September, about 3 or 4 months later, she had recovered. We were able to restart the durvalumab, and she's now resumed. She's had about 8 cycles of durvalumab, and she intends to go through and complete her 12 months, and she's doing very well. So just to show that there are immune-related side effects, but for pulmonary toxicity, the PD-L1 is a little bit less than PD-1, and that is a lot less than CTLA-4. So in terms of pulmonary toxicity, PD-L1 drugs, and as opposed to PD-1 drugs, appear to be safer. You need to know how to manage this. You're managing either radiation or immune checkpoint inhibitor pneumonitis, so sometimes hard to know. Manage it in many ways quite the same way. You can withhold the drug. Certainly, you can give oral steroids, grade 3, grade 4. You need to be getting IV steroids, admitting the patient oxygen, and in rare cases using infliximab. But I have never had to do that. I've given a lot of people durvalumab. So this is just to summarize everything I've just said. Basically, there is now good publications. Anybody's quite happy to give these slides to anybody through the company. There's good evidence that how to manage and how to understand the issue of pneumonitis. Bear in mind that a lot of it is due to radiation and in the radiation field. However, if it's outside the radiation field, it may well be due to pneumonitis. And if it's very severe, you should not re-challenge. in those rare patients where you get grade 3-4 pneumonitis, do not re-challenge. That's just a piece of advice, but that is very uncommon. And this is the real world evidence showing that there was a bit of pneumonitis, but it is mainly grade 1, grade 2. There was no increase in grade 3 to 5 pneumonitis compared to historical controls. And so with that, I think I'm on time, and I'm certainly happy to entertain any questions if there's time. And over to you, Mr. Chairman, Dr. Tiwari. Thank you.
So what we could do is that we'll take the questions at end. The next are there any questions? Let's see, you can take.
So we have chat box doesn't have any question, but if you want to ask anything to Professor Mark, I think that will be great, and then we can shift to the next section.
So
can I ask a question?
Sure, please go ahead.
So Dr. Vincent, wonderful presentation. In this, the Pacific trial, would the analysis of a PDL1, say more than 25%, have selected a better population of patients and probably get a better result?
I think the magnitude of benefit was better. I don't think that they did any better in the control arm than the PD-L1 negative patients, but we can look at that more carefully. But certainly the ability, the magnitude of benefit from the addition of development was better in the higher the PD-L1. And I think we see that in every immune study that there ever has been, that the magnitude of benefit of the immune drug is better the higher the PD-L1 status. That's true for the PD-1s and so on and so forth. So I think it's not a surprise that PD-L1, I think what you're selecting for the PD-L1, high PD-L1 is people who have a bigger benefit. But in the less than 25% group, there was a statistically significant benefit as well. What the concern was around the less than 1%. The completely negative people. That was a concern. But they clearly have a PFS benefit. And of course, you know that the PD-L1 is done pre-radiation from the biopsy. We know that radiation puts up the PD-L1. So you might be PD-L1 negative, if you stick the needle this way as opposed to that way. But after radiation, some of them become PD-L1 positive. So that's so the big group of academics got together in Europe, and they said they did not want any restriction by PD-L1. It was inappropriate. And in North America, particularly Canada, where we want to watch our money, we're Scottish people here, we want to watch money. We are okay to give it in EGFR and in PD-L1 negative patients. We give it to anybody as long as they have not progressed and as long as they're ECOG, reasonably good ECOG status.
Thank you.
So thank you, respected chairperson, and thank you, Professor Mark, for such an excellent deliberation. Looking forward. Sir, can we request you to stop share the slides, please? And we now move. Yeah.
Thank you very much. Goodbye, and keep safe. Hope to see you in person at some time. Thank you.
Thank you so very much, sir. So now we move to the next session, which is a panel discussion, and it's a pleasure to welcome and invite Dr. S.S. Alulkar, sir, Consultant Medical Oncologist at Apollo CBCC Cancer Care, Ahmedabad. Sir will moderate a panel discussion. This is a case-based panel discussion in unresectable stage 3 non-small cell lung cancer. So by the time you can invite your panelists, we have Dr. Bhushan Jade from Pune. He's a radiation oncologist. We have Dr. Akash Tiwari, a consultant medical oncologist at Indore. We have Dr. Praveen Paliwal. He's again a medical oncologist from Bhopal. We have Dr. Shruti Kate from SCG Manavta Cancer from Nasik. We have Dr. Parag Hingde, consultant surgical oncologist from SCG NCHRI from Nagpur. And we have now Dr. Shyam Rawat, senior consultant radiation oncologist at Jabalpur. So good evening, everyone. The stage is set. Over to you, Dr. Shri, sir, for your moderation, please. You have 30 minutes to do the needful.
I think 25 minutes. So you can raise the alarm about 20 minutes, I think.
Okay, sir.
Okay. Thank you, Dr. Shyam and Tarun, for giving me this opportunity. What we'll do is, of course, most of the points have been discussed or highlighted by Dr. Vincent in the previous talk. But as we are on a case discussion, I'll be discussing on a stage 3 NSCLC, which is unresectable. So basically, there is no role of a surgeon here. So quickly, it's a 52-year-old male, and he presented in March 2018. Am I audible, I hope? Am I audible?
Yes, sir, you are audible.
Okay. So he presented with the typical symptoms of weight loss, coughing, and no comorbidities. And there was an opacity in the left upper lobe and middle lobe of the left lung, and some bilateral apical thickening were seen. Some periregional haziness were present. And the chest X-ray again was this one, but the CT scan, I'll show the film, shows again a large heterogeneous mass in the left upper lobe. And there were also some nodes in the mediastinum and a few nodes on the right side, and he had a left-sided lesion. So that would be an N3 disease. So this was the case provided by the company. So the image is not very good, but I think you can get the gist of the case. So it was a large tumor, you can see on the left side, about more than 7 centimeters, and abutting the costal and the mediastinal pleura. And as mentioned previously, there are also some node, but not very visible here on the right side also, right mediastinal node. So if one goes to the diagnosis, it was in a biopsy of this was a poorly differentiated adenocarcinoma, and he had a T4 lesion, N3 disease, making it something like a stage 3C, unresectable. We did an immunohistochemistry, and it was proved to be adenocarcinoma. The question now I'd like to ask the panelists, and I think maybe Dr. Bhushan can take this, is at this stage, would you do PD-L1 or would you do an EGFR in this case? Or say ALK mutation? And maybe then Dr. Akash can.
Definitely. Yeah, since the histology is adenocarcinoma, and we know that in Indian scenario, adenocarcinoma will have EGFR positivity in the tune of more than 50%. So basically, all the markers preferably, but at least EGFR and ALK mutation will be done on this adenocarcinoma specimen.
Anyone would like to differ from it? Dr. Shruti, Dr. Parag Ingle, or do you concur with him?
So, sir, though anyone planning to do a molecular test would not be wrong, but we do not do it routinely in our practice, especially in tumors where we are planning CTRT, because sometimes it then adds to confusion, and then there's this push to add a TKI later on.
Okay, right. So, fine. So as Dr. Vincent said, that could be an effect of giving a radiation therapy and then, upregulating the PD-L1 expression. Therefore, one of the rationale of doing a PD-L1 upfront is to do it before giving radiation, rather than doing say a PD-L1 in a biopsy site when the patient progresses. That's one of the theory. So the treatment, what would you treat this? Would it be a palliative? Would it be a curative intent in this case? Dr. Shyam Ji Rawat and Dr. Shruti?
Yes, sir. Sir, it would be a curative treatment. Patient is non-metastatic. So I would definitely want to do an MRI brain to complete the staging.
Yeah.
And then I would want to discuss in the tumor board in the presence of a surgeon and radiation oncologist, and then decide the plan for him.
But you already ruled out a surgeon's role because your PET scan has shown an N3 disease. So why do you want to invite a surgeon?
But I want him to say that it is not resectable.
Okay, point well taken, yes. Okay, so of course, MDT, as Dr. Shruti said, is, and even Dr. Vincent said, if you have a MDT, the results are better, and especially if it's an academic center. Where you have an MDT, the results are better. So I would not go into the details. There are a lot of evidences for this, and something about, before we go to the N3 disease, some management of N2 disease. And Dr. Praveen Paliwal, can you say something about N2? When you come across an N2 disease, how do you plan out with your surgeon?
Sir, most of the patients, they will go for the concurrent CTRT only, sir. In a very few patients, because hardly we see any stage 3, and in that also the N2, N1 disease is very rare only, sir. N2 mostly they are in the both side. Selected patient, if they are upfront before surgery, they are N2, they mostly they are not operable, sir. Only patient there, some patient which are N1, and after surgery they turn out to N2. Otherwise, if they are upfront N2, they're not operable, sir.
Okay. Anyone else like to add to this? No. Okay. So in this case, obviously there's an N3 disease here. Would you like to go for an invasive mediastinal staging? Would it help anyway, or mediastinal node biopsy? Would it give more information? Dr. Akash Tiwari or someone?
Sir, actually, all PET-based staging should be confirmed by an EBUS. So if the facility is available, I think we should go in for an EBS and confirmation.
So you don't do a mediastinoscopy? Or just
Also not at our center. So we do PET plus EBUS at our center.
Okay. What about EUS? I thought EUS were a little easier. You can access more number of nodes down.
So some stations are accessible by US, some by EBUS, but I think EBUS does the job in most of the cases. So we at our center do EBUS plus PETs.
Okay. So Dr. Shruti, would you go for an invasive staging here, especially mediastinum? Because PET scan already has shown an M3 disease.
So mediastinoscopy is not available at my center, and actually in Nashik it is not available. So we also go by EBUS, and but here when it is a clinically evident N3 disease, I would not want to do it. I mean, only if it is an N1 or an N2 disease, I would want to do an EBUS and confirm, because that is when that might change my management. But here it will not. So
Okay.
I would not do it.
So one other corollary, one situation which we find in Indians, of course, all of you are conversant, is the presence of tuberculosis there. So in that case, you will be downstaging the disease. Or clinically will be N3, but if you do probably an EUS or EBUS and fine. I had a similar case. Of course, it was a breast cancer case, a small disease, but she had extensive mediastinal nodes. We did an EUS and almost practically up 5 to 6 nodes, all different stations were all tuberculosis. So the whole staging differs. So that could be one point probably where you would like to give a chance to the patient to offer a curative surgery in such cases. Anyway. So of course, surgeon we're not considering here because he's not here. So this patient will be surprised here was actually offered by paclitaxel and carboplatin, which we don't usually use in adenocarcinoma, but it's not wrong to use it because, but has a higher toxicity compared to PEMSIS. So he received something like 6 cycles of new adjuvant chemotherapy. Initially, some hypersensitivity was seen. Therefore, it was changed to a NAB paclitaxel. And he completed all the cycles, I think, by September 2018 from March. A PET scan, which I'll show here, shows the partial response. Now, of course, he was planned for chemoradiation as well. What is the usual practice? So he received a total dose of about 66 gray in 33 fractions, and this was completed in November 2018 by the standard techniques, and he tolerated the treatment well. So, of course, Dr. Vincent has said, but just like to concur, I would like to ask the panelists that do you in your practice offer a sequential chemo radiation therapy, or do you straight away go for a concurrent chemo radiation therapy? How would you select your cases for a concurrent chemo radiation therapy? Dr. Bhushan and maybe then Dr. Akash.
Yes, preferably we always use concurrent chemoradiation provided patient fitness is there. And if the patient general condition is not really great, then that is the only reason, only way we can use sequential. But in our practice, somehow 90% of cases we always treat by concurrent chemoradiation way.
Yeah, and of course, a lot of data is there which shows that definitive concurrent chemoradiation is better than sequential. Yes. Dr. Akash, will you add anything to this?
So this is how we also choose a concurrent chemoradiation in most cases, sequential only in poor fitness.
True, very true. Great, yeah. So a real world study was there, published about a couple of years back in ASCO, and our Indian data was there here. Basically, was the Kindle study, and they studied the experience in stage 3 NSCLC. They found that in unresectable patients, concurrent chemoradiotherapy had a favorable outcome compared to a sequential chemoradiation, or even say chemotherapy alone or radiation therapy alone. And this can be seen on the graphs on the right side. The longer one, of course, is the graph with the surgery group, but we're not discussing surgery here. We have discussed this. Now, the considerations for concurrent, any particular choice of drugs for concurrent chemoradiation, single agent, double agent, or if this double agent, which are the drugs you use, Dr. Shyam Ji Rawat? Would you use the standard, like something like a cisplatin, or would you use paclitaxel cisplatin weekly basis? I think Dr. Shyam Parag, Dr. Parag?
Hello?
Yes, please.
Sir, it would be discussed in the tumor board. I am a surgeon. I would discuss with the medical oncologist. I think if your general condition is good, we would prefer a doublet chemotherapy.
Okay, I thought there was no surgeon in the group. Sorry for that. Okay.
I missed the chance. I would like to make a comment regarding operability whenever you
please.
permit.
Go ahead.
Sir, regarding operability for N2 disease, especially if it is a single station, non-bulky N2 disease, after neoadjuvant chemotherapy, we would consider for surgery if the patient is fit from the pulmonary point of view. So single station N2 non-bulky nodes, maybe approximately 1.52 centimeter node, which we feel does not have an perinodal extension radiologically, and a single station N2, we may consider surgery, but that too after mediastinal staging with EBUS. And if EBUS is negative, definitely a mediastinoscopy, and then we can take a call.
So proper staging. Okay.
Yes.
So Dr. Akash, any choice of chemotherapy in your practice?
Sir, we use cisplatin, etoposide, or PEM carbo. Paclitaxel used to use earlier, but we found a lot of pulmonary toxicity with it.
And this is given 3 weekly.
So PEM carbo 3 weekly, sir. Cisplatin, etoposide is standard day 1, day 8, and the 5 days etoposide. Last 2 cisplatin and 5 days etoposide. And so we do not give consolidation chemotherapy. Radiation standard doses 60 gray in our center.
Okay, fine. So for this point of view, is more the better as far as radiation. Of course, 74 gray is more toxic than 60, so it's basically not used when you use a concomitant regimen. Same, we have discussed this, and again, the chemotherapy options to combine will basically depend on what toxicities you're looking at. In my practice, and I think most of PEM-CIS would be there because of the less toxic and manageable toxicity. But in some cases, I have used paclitaxel, but most of the time in these cases, I had to reduce my doses of paclitaxel or maybe carboplatin. As far as the PEM-CIS versus etoposide cisplatin is concerned, not much difference as far as the efficacy is concerned. The p-value was not significant, but how we choose is basically depending on the toxicity profile. The toxicity of EP is worse compared to PEM-CIS, and that is therefore not very easily manageable. Won't go into that. Okay, this patient then developed radiation pneumonitis, and it was in the radiation field, and he was started on the standard steroids. It improved after some time, and by February 2019, he was relatively good. So now the thing is, do we go for consolidation therapy? Because he asked the question, "Aage kya karna? What do I do after this?" This is the usual question which even the breast cancer patients ask after 5 years of endocrine, what next? So consolidation chemotherapy, I think not much of a discussion here. It's more or less out. Radiotherapy, of course, is out. We'll mainly focus in interest of time on the consolidation immunotherapy. So as I mentioned here, consolidation chemo radiation has no benefit here. And we don't usually practice in such cases because the toxicity is much high. So after CRT, consolidation probably not, I would say usually not in most cases. So let's come to the immunotherapy. As late as February 2018, based on the Pacific trial and based on the PFS benefit, the FDA approved this drug for the treatment of unresectable stage 3, and which has not progressed on at least 1 or 2 lines of platinum-based therapy. These are all comers, therefore they were not enriched for PD-L1 expression, and the dose was standard every 2 weeks and given for a year. This was the randomization. I mean, the trial design was basically a 2:1 randomization. Just note that the immunotherapy was given about between 1 to 42 days post chemo, concomitant chemoradiotherapy, not beyond 42 days. And there is now strong evidence that even you can give it later on. So would you in your practice consider durvalumab maintenance post-sequential? If you can just say yes or no in all the panelists. If affordability is not an issue here.
Yes, sir.
Yes, sir.
Yes,
okay.
sir.
Fine. So as Dr. Vincent said, there was a large French observational study, which the Pacific R, or real world data, where they studied about 1,100 patients, and they had received sequential chemoradiotherapy, and high incidence of pneumonitis and endocrinopathies was seen. It was approved in India. So in this, in the Pacific study, there were about 711 patients, about 99% received concomitant chemoradiation therapy. And of these 191 patients had received also induction chemotherapy prior to receiving the CTRT. So That was the slight difference here. NSCT, I don't think I use much in most of our patients. I think most of you would concur with that. As far as the baseline characteristics are concerned, in the Pacific trial, they're almost similar in the Durva and the placebo. It was a 2:1, but if you just go down in the bottom and if you just note for a minute the incidence on the patients having EGFR mutation, about if you see the EGFR positive, about 5 or 6% of the patients, if you see about had, if you see it's about 43 patients had positivity of EGFR, and we'll have some discussion on that. So the peculiar thing of the Pacific study is randomization. In most of the concomitant chemoradiation therapy, the randomization done upfront. So before the patient goes for chemoradiation, you randomize the patient whether it goes for CCRT. In consolidation studies, we always wait after the responses to see whether there's a response, then further we randomize here. But in case of the Pacific study, because they wanted to see the recovery from the radiation therapy, so they waited for about 6 weeks for the concomitant chemoradiation therapy. They gave another 6 weeks or 42 days for the patient to come out of this, and then they randomize the patient depending on the toxicity or the residual disease or the responses. So that was the difference as far as the randomization was concerned. This graph has been shown.
Dr. Teresa, sorry to interrupt. Last 5
giving
minutes
me
to conclude
5
the
minutes.
discussion.
I'll finish in 2 minutes. So the PFS and OS, as Dr. Vincent has said, definitely better. I would just like to, if one just sees here the data here and just focuses on EGFR mutation status, not much response in those who are EGFR positive. And okay, so in your practice, what would you think is the best time to start durvalumab after chemo radiation? Would you wait for the radiation effect to go, say, after 42 days, or would you like to start earlier? Anyone, Dr. Shruti or Dr. Praveen?
Start as soon as possible, so when the patient is fit for the immunotherapy, sir.
So you mean before? So before 42 days as the cutoff as the Pacific trial, or would you like to wait for that?
If the patient is fit earlier, the better, sir, because the data.
Okay. Now, Dr. Shruti, how would you approach?
So around 4 to 6 weeks, sir. If the patient is is a candidate for Durva, then I would want to do the assessment sooner, like around 4 weeks, and just confirm the response and just go ahead. Else, usually we do the assessment around 6 to 8 weeks. But for Durva, I would definitely be wanting to do the response assessment sooner and start sooner, actually.
Okay, right. Okay, so if you just rush through this patient received the durvalumab 82 days after the CTRT. So that was just, and there was a good response. I won't go into the real life data, but just rush through this thing. So it was about 27 cycles by March 2020. He was still on durvalumab and doing well. Just one question before we wrap up is, in a patient of EGFR mutation, if you see the incidence was about 6% in this trial. And tomorrow, if you get a patient with stage 3, similar patient, but EGFR is mutated, would you go for osimertinib or would you go for durvalumab post CTRT? Of course, there is no data post CTRT. These are all adjuvant trials as far as osimertinib is concerned, but would you consider using osimertinib?
So
anyone,
yeah. So as of now, no. Because it has been proven in the study that the patients who are mutated also derive benefit. So my suggestion to the patient will be that we go ahead with immunotherapy and then keep osimertinib as a reserve drug, because it will definitely benefit him anytime when we start it. So because as of now the data is not there, where we do not have any comparison of OSI versus Durva after CTRT. So in that case, we should go sequentially rather than putting it against each other. So
maybe the LAURA trial will give better results later on. Anyone like to use osimertinib in this case where EGFR also is mutated?
So, sir, not for a patient, But say, unfortunately, if I get into this situation, I'll use osimertinib for myself.
For yourself? Oh, okay.
So if you,
Why
we
so?
do not have to justify on a platform
Okay.
the evidence of it, I think it would make
Yeah, no evidence doesn't mean lack of efficacy as of today. So it may work. So basically, if you just go to the Journal of Thoracic Oncology December issue, there was a nice debate in this. It was a controversy when one group discusses against use of durvalumab, osimertinib, durvalumab in patients with GFR mutation versus not user. So it was basically by Suresh Ramalingam, and what he concluded is that you can use and you should use rather durvalumab even in patients with EGFR mutation, although the amount of degree of response is less. But theoretically, because of the enhancement of the PD-L1 receptors after radiation therapy, durvalumab or any immunotherapy as such would work better. So that was the conclusion. Probably with more data coming in, probably even with EGFR mutation, we would use durvalumab upfront in these cases. I think that will be last. Any burning questions, anything, doubts, anything? The panelists? Okay, so Tarun, I think I hand it over to you, and thank you very much, all the panelists. Have a nice evening.
Thank you. So thank you, Dr. Alunka sir, and all the esteemed panelists for such a brilliant discussion on unresectable Stacy NSCLC. So we move forward and we do to the last talk of the day, and this is addressing unmet need in ALK positive NSCLC treatment. Good evening, Dr. Shruti Kate, ma'am. Dr. Shruti Kate will do the justice, consultant and head medical oncology at SCG Manavta Cancer Center at Nasik. So over to you. So, Dr. Siri, sir, if you can just stop sharing the screen. Thank you.
That's what I'm doing.
Thank you. Thank you so very much. Dr. Shruti Kate, ma'am, over to you for your.
Thank you so much for the kind words. Is my voice clear?
Yes, ma'am, we can hear you. Would you mind to share the screen?
No, I think you will have to put it from your end.
Okay. So Aram and Surbi, can we share? Yeah, Dr. Shruti Kate's screens, please. Slides there.
Yes. So the last topic, like Mr. Tarun has rightly said, is actually a brief on the management of ALK positive NSCLC. So what is the unmet need in management of this subgroup of patients? Next slide, please. Which constitutes around 5 to 8% of the population of the NSCLC patients that we see. So definitely this is an important subgroup. These patients behave differently, and with the advent of so many ALK inhibitors, it is very imperative that we go ahead in a right sequence to give the maximum survival to these patients. Next slide, please. So we now have the breakup. You can pick up the mutation on a fish tests, or by IHC using specific antibodies, or you can do the test on a single platform, which is NGS. So which one to choose is an important question. Next slide, please. But unfortunately, for a lung cancer patient, we always have an issue with the tissue. We have some certain tests which need to be done for establishment of the diagnosis, which are absolutely imperative, and a good histology, immunohistochemistry to differentiate between the type of cancer that the patient is having is absolutely necessary. Following this, if you put the patient or subject the patient to multiple tests, each test is going to require certain volume of tissue, and then ultimately there might be a time when you need to do more tests and the tissue is not available. So all those who have counseled a patient for a re-biopsy will definitely feel the pain that I am wanting to highlight here. And the need of the hour is that we have a single platform wherein all the important tests can be done on basis of which you can rightly point towards the best treatment. Next slide, please. And hence the guidelines, ESMO as well as NCCN guidelines now recommend that testing for EGFR, ALK, ROS1 and PDL1 is absolutely recommended. BRAF screening app also is now included. By the time these guidelines were there, the agents were not available, but now we know that you can actually target this tissue, target this mutation as well, and hence identification is important. Next slide, please. So from one mutation, one test, we have to move to one patient, one test. And what it does is not only does it save the precious tissue, but it also saves the precious time. So there are many NGS platforms that are available, but the most common ones include ALK, EGFR, BRAF, ROS1 and MET, which are which have a very fast turnaround time, and these can be easily these can be easily used to identify the disease causing or the driver mutation, like we call them the driver mutations, which can be efficiently targeted. Next slide, please. So the next generation sequencing on a Thermo Fisher platform includes a broad panel which includes both DNA-based sequencing as well as RNA-based sequencing. And then there are companies which sponsor the test and can be available to your patient on a very, very cheap rate. Next slide, please. Coming to the ALK positive advanced NSCLC approvals, these are the spectrum of drugs that are now available. From a time where we had a single agent, we now have multiple agents to use in the first line setting, and subsequently in the second line and the third line setting. So the first agent that was available was crizotinib, and moving forward we have ceritinib, alectinib, brigatinib, lorlatinib, and these second and third generation ALK inhibitors have now been pushed for use in the first line setting as well. So we have a plethora of options to offer to these patients even in the first line setting now. Next slide, please. This is the profile 1014 graph. Next slide, please. Wherein it was proven that crizotinib is the agent that is going to prolong the survival of these patients versus chemotherapy, and a response rate of 74% versus 45% was observed. And subsequently, we have the ASCEND study, which is a parallel study wherein ceritinib was compared with chemotherapy, and you can see that there was a definite a difference in the survival that was offered by ceritinib, the PFS of 16 months versus 8 months, and a response rate which was comparable, but the PFS at 18 months was 50% versus 23% as compared to crizotinib if we compare the two graphs. Next slide, please. And this is another study where this is actually the Asian patient subgroup analysis of the same study, where it was observed that the benefit that was derived was higher in the patients who were of the Asian origin. This was 750 mg fasted ceritinib dosing. Next slide, please. And subsequently, we had a study in only Asian patients, the ASCENT-8, wherein 3 doses were compared head to head for these patients who were ALK positive, serotinib 450 mg after a low fat meal versus serotinib 600 mg compared with the standard standard at that point, serotinib 750 mg in a fasted state. So the intention was to find a dose which was lower and had a lower GI toxicity profile. Next slide, please. And at the same time equally or more efficacious. So it was found that the serotinib 450 mg fed or the dose that was given after a low fat meal was actually better tolerated and also better also more efficacious as compared to the 750 mg fasted serotinib. Next slide, please. Next slide, please. So a head-to-head comparison of these 3 dosings did prove that the serotinib dose of 450 mg after a low-fat meal was actually showing a numerically higher efficacy and less GI toxicity as compared to 750 mg serotinib in a fasted state, which has now become the standard dosing for this drug. Next slide, please. So what is the unmet need in patients of ALK positive metastatic non-small cell lung cancer? It is actually a disease which has a predilection for the CNS involvement. Approximately 70% of the patients may not have brain metastasis at diagnosis, but would eventually develop that over the period of time during progression on the first line treatment. Next slide, please. So we have 2 categories of patients here. One who have brain metastasis at the diagnosis and those who do not have brain metastasis at the diagnosis. Next slide, please. But it is imperative that even those who do not have brain metastasis are treated with an agent which has good penetration into the brain so that the patient does not develop brain metastasis on progression. So this is what was observed in the ASCENT-4 study, that serotinib achieved better PFS versus chemotherapy in patients with and without brain metastasis. And if you can see that those who did not have brain metastasis had a progression-free survival of 26.3 months versus around 9 months in the patients who received chemotherapy. Next slide, please. Yeah, next slide, please. So this is how the patients on progression are going to behave, and the sites of metastasis after ALK inhibitor treatment most commonly is brain, followed by lung, bone, and liver. Next slide, please. So the intracranial responses that are achieved with serotinib here, you can see, are quite wonderful, around a delta of 45.4% if you compare with the chemotherapy arm. Next slide, please. And this is by an independent review committee. The best overall intracranial responses as well as the duration of responses are quite incredible. Next slide, please. This is the comparison of alectinib, which is the 3rd generation ALK inhibitor, versus crizotinib, and again has a very good progression-free survival as well as intracranial penetration, but we have a limited follow-up data as of now. Next slide, please. In the first line setting.
Ma'am, can we request to conclude, please?
Yeah, I'll do that. Next slide, please. Next slide, please. Next slide, please. So the spectrum of toxicity with each of these agents is different, and it is a matter of what you choose one over the above. But you have to, we all believe that serotinib is very well tolerated in the 450 mg with food meal, and it has been compared with alectinib in this study, which was published in 2019. Next slide, please. Wherein an indirect comparison of this alectinib versus serotinib 450 was done using serotinib 750 mg fasted as a comparator. Next slide, please. So it's an anchor, a Buchner anchor method indirect comparison approach. Next slide, please, where you use a common anchor and then compare the different drugs. Next slide, please. To calculate the confidence intervals and the hazard ratio of the drugs compared with the common anchor. Next slide, please. And it was found that the PFS was comparable for alectinib, comparable for alectinib and serotinib with a numerically lower hazard of progression. Next slide, please. However, it was an indirect comparison. Next slide, please. As of now, we do not have any direct comparisons between these agents. Then the other drugs that are available are brigatinib. It is also approved in the first-line setting as per the ALTA study. It has been found to have a comparable activity as compared to alectinib. Again, it was compared with crizotinib in the study. It has a substantial incidence of pulmonary toxicity. Next slide, please. And again, lorlatinib also has been approved in the first-line setting based on the CROWN study, and it does have a strong intracranial activity. So both for brigatinib as well as lorlatinib, we have a follow-up data which is around 9 to 11 months. Next slide, please. And it is advisable that though all these agents are approved in the first line setting, alectinib, brigatinib, lorlatinib, and serotinib, it is advisable that lorlatinib be reserved for a second line setting. Next slide, please. So the aim is to use a drug that is penetrable in the brain, has a rapid response, and you have a second line agent available post progression after its use. Next slide, please. So this is how, if you use sequentially the drugs, serotinib followed by lorlatinib followed by chemotherapy versus alectinib, lorlatinib, chemotherapy. So next slide, please. The investigational drug that is the newest kid on the block, ensartinib, a 290 patient trial, the EXALT-3, has given a median PFS of 26 months versus 13 months, again compared with crizotinib. This is currently under investigation. Next slide, please. So treatment post-progression for these patients is also an unmet need, and lorlatinib is found to be active against all the known ALK inhibitor resistant mutations, including the G122R. So the FDA approval for in the second line setting does not require biomarker based tests, and it can be used for any progression post serotinib or alectinib. And in this setting, actually brigatinib or alectinib cannot be advised. Next slide, please. So it is wise to keep lorlatinib for the second line use. That is what is recommended. Thank you so much. I hope I have covered the unmet need. Thank you.
Wonderful. Thank you so very much, ma'am, for such a detailed discussion on ALK positive. So can we have the final words? Dr. Shyam Agrawal, sir, good evening again. Request if you can just put a vote of thanks and then we close the meeting.
Yeah, thank you very much, Tarun. And it was really very nice, exciting. I think it can be called as master class of lung cancer. And thank you very much, everyone who participated. It has been a lot of informative and learning experiences to me, especially about the new molecules like durvalumab and kind of iOS in different settings. And of course, Dr. Mark David has made a lot of points and which may be applicable to country like India, but definitely a lot of learnings. And last but not the least, the updated on the unmet need on ALK positivity by Dr. Shruti was really wonderful. I sincerely thank to everyone who participated once again and making this webinar a great success. And I would like to thank to team of AstraZeneca, and they did a really wonderful job. And I hope we can have more such meetings in future to increase the survival curves in lung cancers. Thanks once again, and good night.
So thank you so very much, sir, and we thank all the participants. We thank all the faculty on behalf of the organizing team, my colleagues Aram and Surbi. Good night. Stay safe. Stay blessed. Till then, we meet again. Thank you so very much.